Hello. Can you hear me?
Yes, fine.
Hi, Dr. Andy. How are you?
I'm fine. You?
Thank you. Hi,
Good.
Dr. Farm. How are you?
Hi, I'm good, thank you. And yourself?
Yeah, I am okay. Thank you. Good to see you.
So we check the presentation. What?
And you can check your presentation later. So now Professor Palm will start his lecture. Then before 10 minutes of your lecture, we will check your presentation together.
Okay. So.
Okay, thank you. Good to see you here.
Yeah. Nice to see you.
Thank you.
How is in London?
Yeah, good. Nice. Yeah.
It's nice and warm at the minute here. We're having some good weather.
Exactly.
Yeah. So
Okay, Basim,
see you later. Yes.
Okay.
10 minutes before my presentation. Yeah.
Yes. Yeah.
Okay. Super.
We are starting the event now. Yeah. Okay.
Okay. Thank you very much. Good
Thank
luck.
you very much. See you later. Bye-bye.
Ciao.
Welcome all participants in the first Knightsbridge Academy Dubai Center. You are very welcome to join us and share all the lectures of very nice speakers. And I will ask Dr. Zainab Balat to introduce the speakers and give the CV of all the speakers.
Okay, thank you. Good afternoon, ladies and gentlemen. Welcome to Knightsbridge Academy Symposium. I'm Dr. Zeynep Balat from Istanbul, Turkey. And it's an honor for me to introduce distinguished speakers of Knightsbridge Academy Symposium. And our first speaker is Professor Parmjit Singh from United Kingdom. After qualifying as a dentist from the University of Newcastle in 2001, Parmjit relocated to London, where he worked in general practice and at 3 undergraduate teaching hospitals. His specialist orthodontic training took place in London, Essex, and Suffolk. He is trained to consultant level, the highest level for a United Kingdom orthodontist, and has worked at the Chelsea and Westminster Hospital in London and Ipswich Hospital as a locum consultant. Parmjit's special interests include adult orthodontics as well as orthodontic retention, a subject area he has both lectured and published in. He provides the full range of orthodontic appliances, including incognito, lingual braces, and Invisalign. He truly enjoys teaching and has been awarded the certificate in learning and teaching. He is a professor of orthodontics at the College of Medicine and Dentistry, Birmingham, where he is course director for the Master in Orthodontics and the Master in Clinical Orthodontics. The course has collaborations with both BPP University and the University of Ulster. He is also the orthodontic lead for the Diploma in Orthodontics that is delivered at the Ghana Institute of Management and Public Administration, Accra, Ghana, in collaboration with the City of London Dental School, and runs a certificate in orthodontics in Istanbul, Turkey, in collaboration with the Vesta Academy. Parmjit is a member of the British Orthodontic Society and the European Orthodontic Society. He is a fellow of the Royal College of Surgeons of England and associate fellow of the Higher Education Academy. He spends his time between London and Spain and enjoys cycling, hiking, and dive in his spare time. The topic of his speech is adult orthodontics. Is it any different to orthodontic treatments in the child patients? Now the chair is yours, Dr. Singh. Thank you.
Thank you very much, Zeynep, for that very kind introduction. So yes, that is the subject of my presentation, adult orthodontics. And does it really matter when we're treating adults? compared to children? How relevant is it that we have to consider extra things when an adult attends to our practice compared to a child? Some of you might be thinking, is this really relevant? Well, one way to look at this is when we have a child patient, they feel fear towards us because they're scared. They think we're going to give them pain. Whereas the adult patient is able to manage that pain, but probably fears much more the bill that we're going to give them at the end of the treatment for our charges and professional fees. But let's put that to one side and talk about adults versus children on a serious note. When we have a patient that attends with this kind of orthodontic problem, a patient in their late 50s, she wants to have her smile improved because she wants it to look like how it did when she was younger. What might we discuss and offer this patient? Well, let's take a closer look at her. This is her from the front smiling. This is a close-up view of her smile. And this is a buccal view of her right side of the canine region. And we should already start to think about some of the problems that we see here, but also about some of the good features about this patient's smile. Her smile on the whole is actually very good. She has good lip support. She's got good gingival health. She's got good upper incisor show. But we can see there are height differences between the incisors. There are some rotations. There is some tooth wear. There is some gingival recession, and there are some dark triangles. And we can think about how we might be able to address some of those orthodontic or dental problems. But let's take a closer look inside her mouth. When you look at the upper occlusal view, you'll see that the problems are probably more significant than we first thought when we were looking at her smile from in front. Here we can see there are a number of teeth that are heavily filled. We can see there is a crowned tooth. We can see there is a missing premolar on the top left side. But probably most obvious at all is that her malocclusion has been masked by some very thick porcelain laminate veneers to make her teeth look straighter than they actually are. So now that we have a bit more information about this patient, what options might we discuss with her? Well, there are three approaches that we might take. The first is you might say to her, let's not do any orthodontics. You're in your late 50s, and let's think about doing some restorative treatment, so cosmetic treatment to make your smile look better. And cosmetic treatment has been promoted by celebrities and sports personalities all around the world. And we see before and after smiles like this, where there has been predominantly cosmetic bonding that's been done to make these smiles look as nice as they do look. The other option that we might want to explore with this patient is orthodontic treatment. And we would need to think quite carefully about what we might be able to achieve with orthodontic treatment. And orthodontics is promoted by celebrities and royalty like this. And the two things that both of these individuals have in common is that they both are teenage patients at the start of treatment. They're not adults. So that means that we have a third approach that we could discuss with this adult patient, and that is multidisciplinary treatment. And by that, what I mean is treatment that involves not just one specialty. So not just orthodontics, not just cosmetic dentistry or restorative dentistry, but a combination of specialties working together to provide the best possible result. And the celebrity that probably demonstrates multidisciplinary treatment the best, and one that we're all familiar with, the celebrity Tom Cruise, who had a missing upper lateral incisor. He has a big centerline shift, and he had a combination of orthodontics and then bonding to make his smile look acceptable. I think we would all agree that the smile here is not perfect, but it is acceptable. He has a big centerline shift. There are differences in gingival margin heights and tooth dimensions and proportions, but it's a lot better than what he had as a child and what he had as a young adult. So those are the three approaches that when a patient comes to us seeking orthodontic treatment as an adult, we will want to explore with them. Can we do just restorative treatment? Can we do just orthodontics? Or do we need to do multidisciplinary treatment? And for most adults, they are going to be falling into that third group. So let's talk a bit more about adult orthodontics. Are we only starting to talk about it now? No, this has been talked about since the 1800s. And in the 1880s, Norman Kingsley said, it may be regarded as settled fact that there are hardly any limits to the age when movement of teeth might not succeed. So orthodontics can be done at any age. Does that mean every patient is suitable? Well, we'll talk about that as the presentation progresses. The two areas I'm going to focus on is the orthodontic consultation. What must we pay extra attention to when a patient attends our clinic or our office wanting orthodontic treatment as an adult? What do we need to explore in detail to make sure that the treatment we offer them is appropriate? And then the second thing I'm going to talk about towards the end of the presentation is what specific challenges are there in the adult orthodontic patient once we start treatment. Now here is a chart of what we do for every orthodontic patient, whether they're an adult or a child. We take a detailed history, we perform our clinical examination, and then we come up with an orthodontic problem list. And then what we do is we tell the patient what the optimal orthodontic treatment plan is. And this happens for every orthodontic patient that we see. You'll see that there are 3 question marks there because these question marks relate to what additional steps we must take in the adult orthodontic patient. We must look for associated pathology. We must solve any of that associated pathology, and then we will talk about compromised orthodontic treatment plans or treatment plan. So let's start with the history and the clinical examination. What must we pay extra attention to when we have an adult sitting in our dental chair wanting orthodontic treatment? We will look at 8 different factors, and I'll go through each of these in turn, starting with what do you want to change and why do you want to change it now? When a patient comes to us with this kind of presentation, and if we did a very quick evaluation of this patient's alignment and occlusion, we can see that there is some mild crowding in the upper arch, there is some mild crowding in the lower arch, there is a small centerline shift. There's some difference in gingival marginal heights of the upper central incisors. There might be a crossbite tendency on this right side. So these are some of the orthodontic problems that we might want to solve for this patient. What's different in children compared to adults is when children sit in our chair, they come and want us to tell them what needs to be fixed. They come to us and we detect the problems and we tell them what we think they need to have treated. Adults are different because they come to us and they say, these are the problems that I want to have fixed. This patient here, the picture that you see, they may come to us saying, we want our smile to be wider because it's not wide enough. So we need to be very careful about recording what the patient wants to change. Let's look at this patient in a little bit more detail, because this is Jordan, a patient that started treatment with me, and this is him before I placed any orthodontic appliances in his mouth. This is the front of his mouth, and this is his buccal occlusion. So sorry, this is a different patient to the picture I showed you earlier. So we have some mild crowding in the upper and lower arches. We've got some proclined upper and lower teeth. We've got mild crowding clearly visible in the upper arch and mild crowding clearly visible in the lower arch. And there is a missing tooth here on the bottom left side. These are the orthodontic problems, but actually the dental problems here you should be able to see is he's got some recession on lower incisors. He's got less than ideal mouth care, and he's got some recession on some of his posterior teeth. Now, what Ackerman said almost 50 years ago is that adult orthodontics is concerned with striking a balance between achieving optimal proximal and occlusal contacts of the teeth, acceptable dentofacial aesthetics, normal function, and reasonable stability. So if we go back and look at this patient, what Ackerman was saying was that for this patient, we need to be absolutely clear with them that we cannot give them a perfect result at the end. We will need to have some compromises somewhere because we may want to minimize the movement of some of these molar teeth that have got significant recession. We may not be able to easily address this space of the missing molar on the bottom left side. We may not even be able to give a full centerline correction at the end of treatment because the centerline problem he has is so significant. So in the adult patient, we need to be very clear about what they want to change because we cannot often fix all of the problems that they come in wanting to have fixed. Why now? Well, we know that very few features of malocclusion improve with time. And this is from some US studies done in the 1980s. We know that all orthodontic problems, but in particular crowding, will get worse as we get older. In fact, about one of the few things that gets better with time in the healthy adult mouth is spacing. If a patient has spacing as a teenager, usually the spacing gets less as they get older. Let's look at the kind of patients that we might have attending our offices or our surgeries. We will see young adults wanting orthodontics, and these are going to be patients in their 20s and 30s because they should have been treated as teenagers, and either they didn't want treatment, they might not have been able to afford it, or they were considered suitable for surgery, so treatment was delayed. And then we have those cases that had treatment as teenagers, but didn't wear retainers, and then there has been some orthodontic relapse. So these are the young adults we're going to see in their 20s and 30s. And then we're going to see the older adult over the age of 40, where things have started to go wrong in that patient's mouth. The dentition has started to deteriorate. They've had teeth taken out or they've had teeth restored, and they've started to develop secondary malocclusions. So here, a patient in their 20s or 30s who's got a class 3 malocclusion, and she should really either have been treated when she was younger, or treatment was delayed because surgery was considered most appropriate for her, and surgery would not be done until she had finished growing. And then we have the patient in her 40s who's had multiple teeth extracted and restored. There has been over-eruption of some of the teeth, and there's been tipping of some of the teeth. So here we've got a secondary malocclusion starting to develop. So these are the two groups of patients we're mostly going to see in our surgeries as adults wanting orthodontic treatment in their 20s or 30s, and then those that have got deteriorating dentitions over the age of 40. But increasingly, we are seeing patients like this, patients in their 50s, 60s, and 70s who want problems like this resolved, lower incisor crowding. And this is happening, we think, because as we get older, you start to show more and more of your lower teeth as the upper and lower lips fall south. And these patients become more aware of the lower incisor crowding because it's more visible, and they want to have this corrected. And I've treated patients in their 60s and their 70s before very successfully. So we may have many reasons as to why we think patients are coming to us as adults. We think that adults are keeping their teeth for longer and they're more aware of their teeth. We know that we have got more conservative approaches where we don't need to take out teeth, and orthodontics has become much more socially acceptable with a bigger range of orthodontic options. Orthodontics is more affordable. We've got more capacity to treat patients, and increasingly we're doing a lot of retreatments. So about 1 in 3 of the adults that I treat are patients who've had treatment done before, either as teenagers or as young adults. The other thing recently that has probably increased adults wanting to have orthodontic treatment and has therefore increased the number of adults that we see in our surgeries or in our offices is companies like this: Candid, Smile Love, Snap Correct. Now you might think, I've not heard of any of these. Well, if you haven't, the one you probably will have heard of is Smile Direct Club. And these are companies that are marketing orthodontic treatment directly to the patient or the consumer. The patient does not see a dentist or an orthodontist, and they deal directly with a company. And they offer treatments like this, clear aligners, for around £1,500. Now, there are lots of ethical and legal issues related to this type of treatment. And regardless of what you or I might think about this model of delivering orthodontics, what these companies are doing is they are promoting orthodontics for adults. And indirectly, what that means is we are getting more patients coming to us saying, I've heard that adults can have treatment. I've heard that aligners can be used. What do you offer that might be able to help me? What about the patient? What reasons do patients have for wanting to come to us as adults? And this was a study I did looking at adults' motivation for seeking treatment in primary care, so in the dental office or the dental practice. And the reasons that patients reported as to why they want to have treatment as an adult are these. They said they never had treatment recommended before. They didn't want to wear braces as a teenager. They didn't realize that adults could have braces. Orthodontics wasn't available in their area. Their parents were unaware of brace treatment. They were scared of us. They couldn't afford our fees. They didn't have invisible or discrete options available to them, and the problem only occurred recently. So there's a multitude of reasons as to why patients will come to us at a particular point in time. So that's a little bit about exploring what they want to change. Make sure that they are very clear and you record exactly what they want to change, because later you will need to tell them what you can fix and what you cannot fix. Find out why they've come to you now. And next, we're going to look at dental history and previous orthodontics. And dental history is going to include a list of things that we want to question patients about. I'm not going to go through this list one by one. What I'm going to show you is a series of images and x-rays to show you why going through a detailed dental history is important. Previous orthodontics. Why is it important to find out if a patient has had orthodontics before? Well, because when we take our baseline records, and a panoramic radiograph is a frequent baseline record, you might say, well, this doesn't show anything too unusual, nothing here that's going to affect any additional treatment I'm going to provide for this patient. Well, let's take a closer look. The upper incisor region, same patient, same upper incisors, and they've had significant root resorption of those upper front teeth. So you might want to think carefully about whether you want to do any additional orthodontic treatment. What about when the patient comes to us with this kind of presentation? They've got fairly straight teeth, but the molars are not in class 1. There is a scissor bite in the upper 4 region. Well, it's important to find out what treatment was provided before, because if the dentist or orthodontist had used lots of class 2 mechanics to try to fix this problem and they weren't able to, there is nothing you or I are going to be able to do very easily that will be able to fix this problem the second time round. make sure that patients are fully committed to long-term retention. Remember, in orthodontics, moving teeth is the easy part. The difficult part is keeping teeth where we have put them. And the only real way that we know how to do that is by giving patients retainers and telling they need to wear these retainers for as long as they want their teeth to stay in that new position. We want to find out not just about previous orthodontics, but also about trauma to any of their teeth. Because when you look at this panoramic radiograph, you can see that the upper incisors look suspicious, and we take a periapical X-ray and you can see the extent of the root resorption of particularly the upper right central incisor. Do we really want to be doing more orthodontics for this patient? Or do we want to say to them, no treatment is the best treatment? Or do we look for some kind of compromise? What about questions about the temporomandibular joint and temporomandibular joint dysfunction? Here a patient had a combination of orthodontics and surgery before, and look at the heads of the condyles of this patient. Do you really want to be putting forces on this patient's teeth and on this patient's intermaxillary arches that could potentially aggravate the problems that you see in the temporomandibular joint? Why do we need to ask about habits? Well, we know that if habits continue, then any problems that we fix, like this open bite, will return. So we need to make sure we ask about habits. And the temporomandibular joint, even in the absence of the patient telling us they're having no problems, should be evaluated. Because when you look at the heads of the right and the left condyles, you will see there is a difference in volume on the right side compared to the left side. And then we need to look at dental disease, things like periodontal problems, things like root-filled teeth, things like bone loss, tooth loss, over-erupted teeth, heavily restored teeth, like these lower anteriors, canines. So lots of things that need to be evaluated in detail in the adult orthodontic patient when it comes to dental history. So we've now talked about a detailed dental history and questioning the patient about previous orthodontics. What about medical and family history? Well, adults are more likely to have complex medical problems, but my personal view is there are hardly any contraindications for adults to not have orthodontic treatment because of their medical problem. Now, you will always find one or two very extreme examples, but most patients, providing their medical problems are well controlled and well managed, should be able to have orthodontic treatment. But we may need to modify the treatment plan slightly. And here, a patient who developed an allergy to nickel intraorally, so inside the mouth. And for these patients, there are alternatives available. Things like ceramic brackets. And even when a patient has a latex allergy, then we can find non-latex alternatives that we can use in that patient's mouth. In terms of family history, it's useful to ask patients about parents and grandparents and brothers and sisters to see whether there might be any patterns developing in terms of class 3 malocclusions in particular. And then lastly, the 2 points that I've put in bold and I've underlined is motivation for treatment and expectations of treatment. Motivation is important because every patient may not be suitable. And here you can see a picture of a patient with an anterior open bite. Only the terminal molars are touching. The patient has less than ideal mouth care. There is crowding in both arches. Is this patient really suitable? If they are, then let's assess the severity of the malocclusion. Let's make sure they are motivated, and let's make sure they have got realistic expectations. Because this malocclusion, if we did orthodontics alone, is unlikely to end up with a perfect result. And we need to make sure that the patient is aware of that, so their expectations are aligned with what we can do for them. In terms of assessing severity, what we must do is look at which cases need surgical management and which require incisor movement to camouflage the skeletal problem. And this is where working with other team members to give the patient the best possible outcome is paramount. So if we just go back to that patient I just showed you, if this patient came to us wanting a perfect result and we said, we can do orthodontics, we might take out some teeth and we use some orthodontics to align the teeth and improve the bite, but you're not going to have an ideal bite at the end. We have probably done this patient a disservice. We have let them down, because what we should be saying to them is, yes, that is an option, but if you want a perfect result, then you're probably going to need a combination of orthodontics with corrective jaw surgery. So let's look at assessing severity. So how much of this problem that we see here, the spacing and the anterior open bite, is due to the patient's bones or the skeleton, how much it is due to the soft tissues, and how much of it is due to the teeth or tooth positions. How about this patient? Class 3 malocclusion. His lower jaw is further forwards, his upper jaw is set back a little bit. Is this a difficult malocclusion to treat? Well, one of the things as you develop and evolve in orthodontics is that you'll learn that to look for jaw displacements. This patient actually bites like this, and then the jaw displaces forwards. And this is actually quite a straightforward case to treat with orthodontics. Why did I say that motivation was so important when it comes to our patients, not just teenagers, but adults? Well, because if patients are not motivated, they don't look after their brace, they don't look after their mouths, we end up with problems like this, gingival enlargement. Now, this is reversible, and when the patient starts brushing their teeth properly again, this will get better. So, yes, I agree, motivation is important, but for problems like this that are reversible, we don't get too worried. But problems like this, we do get worried, because this is irreversible. These white spots or decalcifications will stay with this patient for the rest of their life. They won't get better unless we do some kind of cosmetic bonding. Now, some of them, like the one here and here, might improve, and there are techniques that we can use to try to improve them, but white spots like this and this will really need to be accepted or covered up. So motivation is important. Motivation is important not just because of mouth care, but because of the result that we want to achieve. If we want to give the patient the perfect class 1 result, patients need to be compliant with the instructions that we give them. And here, if we give a patient class 2 elastics like this, they need to wear them, because if they don't wear them, we will not get the result that we are looking for. And there will be some of you who are doing aligner treatments, and aligner treatments are unique in that they are completely dependent on patient compliance. Someone once said to me, if you have a difficult patient, give them an aligner, because when the treatment doesn't work, you can blame the patient. You can say, well, this aligner treatment is based purely on you wearing the aligner. And if it hasn't worked, it's because you haven't worn it. And these are the kind of problems that we see when sometimes compliance is less than ideal. There are other reasons why we get gaps developing between aligners and tooth, but compliance is one of them. And finally, expectations. What does this patient want as a consequence of orthodontic treatment? If they want straight teeth, that for me is easy. Do they want their bite to be better? So a positive overjet and overbite? That's also probably relatively straightforward. Do they want these dark triangles to go? A bit more difficult. Do they want this recession to not be there? Practically impossible to fix. So make sure that patients are very clear about what we can and cannot do for them. What about these two patients? What two things do they have in common? Well, the thing they have in common is they both have a gingival smile. They show quite a lot of gingival tissue when they smile. And this is something that in orthodontics can be fixed, but it's not fixed very easily. And the solutions are not straightforward. So patients, if they want this gummy smile to be fixed, need to be aware that treatment will be very involved, or they will need to accept that they will have increased gingival show on smiling. And then a patient like this, and this is probably one of the worst types of patients to have attending in our offices or surgeries. A patient that says, this is what my teeth look like. I want the teeth to be completely straight, and what I don't like is my central incisors are different heights, my lateral incisors are different heights, my lateral incisors are different dimensions. This patient has already got a reasonable outcome, and what they want is they want to go from a good result to a perfect result. And these are the patients that want perfection, and sometimes they will test us and test our skill, test our ability, and test our patience. So be very cautious about the patient that comes to us with already quite a good result, wanting perfection. So what we've done is we've gone through the history and the clinical examination. Now, if there's any associated pathology, this needs to be dealt with first. So we need to look for associated pathology, and then we need to solve or fix that associated pathology. We come up with the optimum orthodontic treatment plan, and then we come up with a compromised orthodontic treatment plan. And by that, what I mean is that not everything is going to be perfect at the end in this adult patient. Let's look more at the treatment plan. The 5 factors that we consider is the aesthetics, the occlusion, stability, and then we look for the ideal plan. So the patient knows what the ideal should look like, and then we tell them what the compromise would be. Because sometimes we cannot achieve the ideal. In fact, a lot of the time, we cannot achieve the ideal. Because here is a patient, and she comes to us wanting us to fix her gummy smile. She wants to have a normal occlusion. She wants to have straight teeth. But actually, when you have a look, you can see that she's already had some teeth taken out in the top jaw. So this is a patient that she wants perfection, then she's probably not going to get it, or it's not going to be achieved very easily. And there's going to be a compromise. So let's talk more about the challenges in the orthodontic patient that comes to us as an adult. We know that skeletal problems will not be easy to fix because growth has now really slowed down. Deep bites, because of growth, will not resolve easily, and crossbite correction will remain a challenge. So here we have a patient with a very deep bite. They're an adult. So this in a child patient is hard enough to fix. In an adult, it becomes really difficult. Here we've got crossbites in an adult patient on both sides on the buccal teeth. Again, in a child patient, relatively straightforward to fix. In an adult patient, really quite difficult. The other factor that has to be considered is psychology, because child patients generally will accept what we offer them. They also have a very high adaptive capacity. So these patients are not challenges for us because they'll do what we tell them. And when we leave a wire a little bit long, or we leave something sharp in the mouth, or something is uncomfortable, they tend to just cope with it and carry on. Whereas the adult patient will ask questions at every step. They will require explanations for everything that we do, and they are not very tolerant of discomfort. They're more likely to complain about problems with pain, speech, and soft tissue discomfort, and also cost, because they are often paying more than our teenage patients. And an adult patient will expect sometimes us to make modifications like placing composite on this hook so that it doesn't irritate the cheek. They also expect aesthetic options like this ceramic bracket system at the top, but ceramic brackets are not without their own problems because they fracture, and even the aesthetic wires that we use will lose their coating. So you can now start to see how an adult patient that is very demanding will start to take up more and more of your chairside time. And that's why I think we should always charge our adult patients more than we charge our child patients. I'm not going to talk in detail about mechanics, but I am going to just mention a few sentences about anchorage control, because in the adult patient, we have second and third molars. So this may help us with our anchorage. We may also have implants present, and this will also assist us. And adults may be more tolerant of having mini screws or mini implants. However, adults also have less bone support if they've lost some of their alveolar bone. They may have had tooth loss and there will have been mesial drift. So anchorage control in the adult patient can both be better or maybe less than in a child patient. We also have non-enamel surfaces in the adult patient, surfaces such as ceramic, precious metal, non-precious metal, and plastic. And by that I mean composite. And here's an adult patient that I treated, and she's got porcelain crowns on those upper central incisors. And we will need to modify our bonding technique for the adult patient who's got non-enamel surfaces like this. And we would need to use hydrofluoric acid, and we will need to use a silane or silane coupling agent. And then when we've got problems of bonding to posterior teeth, like this molar here, because this is a porcelain crown, we may choose to use a band rather than an orthodontic tube. And even at the end stage of treatment, when we move to retention, we have a porcelain crown here. We will need to modify our bonding technique when we place our fixed retainer. So adults bring with them challenges because not all surfaces of teeth are going to be virgin enamel that is intact. Adults will also come to us with periodontal disease more often than children. And without going through the history of periodontal disease, what you must always make sure is if a patient has got periodontal disease, make sure that you have taken a baseline charting. So you've done a baseline pocket charting, and there is an absence of bleeding for at least 3 months before you start any orthodontic treatment. Bleeding on probing would be a measure of the activity of disease. So once bleeding on probing has virtually gone, this means the disease is now under control. Once it's been under control for 3 months, you can start thinking about starting orthodontic treatment. But remember, you may want to not go for the ideal plan, but go for a compromised plan. Because here we have a patient who's got controlled periodontal disease. She's got some spacing in the upper arch. She's got attachment loss here in the lower left central incisor. She's already got some teeth missing in the upper arch, 2 premolars. And rather than achieve a perfect result for her, a compromise was adopted, and we aligned her arches and took out the compromised lower incisor. And this is her at the end of treatment. So this is not a perfect result, but what this has done is given the patient's periodontal problems, it's given her an acceptable result. Here, another patient with quite a lot of dental disease. You can see that she's got some failing crowns in the upper anterior region. She has a little bit of attachment loss, and she's got almost an edge-to-edge bite. And in order to restore these crowns at the top, what I did was I sacrificed a lower incisor, and you can see the lower arch has been bonded. So limited treatment. The upper arch has not been touched. And what we've done is we've aligned her lower arch. You can see here I've placed some composite to make it look like there isn't a big gap there, and that composite is gradually reduced. And then this is her at the end of treatment. We've given her a positive overjet and overbite. She has a dark triangle, and she was warned about this at the start of treatment. So what we've done for her is we've given her a compromised plan to align the lower teeth, to give her a positive overjet and overbite, and now these crowns in the upper arch can be restored. Let's look at another case where the dentition is really compromised. What about this patient? Is there very much we might be able to do for him with orthodontic treatment? You might say, well, he needs lots of other treatments before he has any orthodontics. Let's take a look at his panoramic radiograph. This is what it looks like. And let's look at the lower front teeth in particular. He has a lesion on the lower central incisor. So this is his lower arch, and that central incisor was sacrificed, so it was taken out. Limited treatment, lower arch only. The arch has been bonded, the teeth are aligning, and this is his lower arch finished. And now he will have restorative treatment to replace some of the missing upper teeth, but he's got aligned lower teeth, and he may or may not want to get some bonding done to the tooth loss that he's suffered on those lower anterior teeth. What about this case? So a patient who has got lots of missing teeth, they've still got some of their primary or deciduous teeth. Is there anything that orthodontics can do for this patient? Or do they just need to have restorative treatment? Well, I treated this patient with orthodontics, and what I did was opened the bite at the front. So now there is plenty of space in the lower arch for implants or a bridge if the patient wanted a bridge. Here, there is inadequate space. So even when you see a patient like this, where you think, actually, there's not a lot that I can do with orthodontic treatment because there's not a lot of teeth there, there is often something that we might be able to do. And this is where the importance of working with other team members is highlighted, because the people who are going to place the implants down here are guiding me and telling me how much space they want here. So I know how much I need to intrude these upper incisors. And this is the patient from the upper and lower occlusal view. You can see the extent of his hypodontia. He's missing upper 2s and 3s. He's missing lower 5s, and he's missing all of his lower 3 to 3. And then something that we can give a more acceptable result to, this is a patient who's got 2 missing lower incisors, and compromise plan again, we took out 2 upper teeth, or I took out 2 upper teeth, and this is him at the end of treatment. We compromise on the overjet and overbite because we've had 2 lower incisors missing rather than 2 lower premolars. And finally, for very simple treatment, you may want to place brackets just on a few teeth. So here is an adult patient. This is how he presented. He had a bridge replacing a lower incisor. And my restorative dentist said to me, Palm, the teeth on either side of that bridge need to be improved. Before treatment, the long axis of those lower incisors was like that. Can you place just a few brackets and over a few months, move the roots of those teeth away from where I'm going to place my implant? So this was very limited objective treatment to move the incisors closer together, so we've got space just for one lower incisor, but also to reapproximate the roots so the roots become divergent from where the implant would be placed. So are adults easier to treat than children? I think they are, because they bring with them many challenges, not just in terms of patient management and managing patients' expectations, but also in terms of the treatment that we need to do, because growth is not on our side, and we are often starting with a very compromised start position. And this patient that I showed you earlier on in the presentation is a patient that I treated with orthodontics, and then he was passed to my restorative dentist colleagues, who then provided the restorative treatment, so a combination of bonding and implants and crowns. Now, why have I spent the last 40 minutes talking about adults and making sure that expectations are aligned with what you can deliver? That's because a lot of complaints, a lot of litigation, letters from solicitors and letters from the regulator relate to orthodontics in the adult patient. And this was a piece I published in the British Dental Journal a few years ago. And this is something that's just been published between myself and one of my students at the university, where we reviewed the cases that went before our regulator in the UK, the General Dental Council, that related to orthodontics. And without going through those 2 articles, what I can summarize is that most of the claims feature general dentists, not orthodontics. And most of the claims and allegations relate to assessment and diagnosis, poor records, deficiencies in consent and alternative treatments, failure to anticipate and recognize problems, failure to recognize absence of space to move teeth, failure to manage expectations, failure to mention the possible need for some fixed treatment, long-term retention, failure to challenge treatment plans made by the laboratory, and patient compliance. Now, that list I've just spent a minute reading through, when you look through that list, all of that is to do with communication with the patient and what we do before we start any treatment, before we place the first aligner in the patient's mouth, before we place the first bracket or arch wire in that patient's mouth. So how can we make sure that we can treat patients successfully and we can have a profitable orthodontic career treating adults, and our patients will leave happy and we will leave happy, and that will make us want to do more adult orthodontics. This list of 11 always offer all treatment options. Tell a patient that no treatment is an option. Compromised plan, ideal plan that may or may not involve surgery. Give them realistic aims. Tell them what you can and cannot achieve. So what are the limitations? Make sure you provide this in writing and give them a consent form with all the risks and highlight any risks that are relevant. I told you earlier, a lot of adult patients will have dark triangles at the end of treatment. Make sure patients are aware of that. Make sure you give them realistic expectations in relation to duration, because if they say they're getting married in October, you and I know that we probably cannot fix their orthodontic problems by October. It's only 3 or 4 months away. Tell them that they're going to need indefinite retention, collect good records at the start and during treatment, make sure the patient is clear about what is included and excluded in terms of price, and make sure the patient knows how they should be paying, all at the beginning or as treatment progresses. So I hope I've given you a little bit of a flavor of some of the questioning that must go on in the consultation phase of the adult orthodontic patient, and also some of the challenges that we face. And I've shown you some cases, not cases that have been finished perfectly, but cases where the patient starts with a compromise, and we are still going to finish with a compromise. But what we've done is we've satisfied the patient, and they are going to leave our surgeries with a smile that they find acceptable and are happy with. They're not leaving with something that is perfect, because that cannot often be achieved. Now, in time, you will have, like me, patients that you treat as children, and that one day they might come back as adults, and that you'll treat as an adult. And this was a patient that I treated for a number of years until he became an adult. Thank you very much for listening. I will take any questions if there are any questions for me.
Thank you for your presentation, Pam. It was another bright presentation like before. Thank you very much. We have very limited time, so for the next lecture, if anyone has any lecture. No, sure, yes, sorry.
I mean, if there are any questions, if we are pushed for time, people can type them in the chat box, and I can just respond from the chat box.
Okay, okay, perfect. Thank you. Thank you very much.
All right. Thank you.
Bye-bye. See you next time. Dear colleagues, we will start the next presentation in 5 minutes with Professor Esra Uzerçelik.
Can you open voice
I would like to change my background. How can I change it? Hi, can you hear me?
Hi.
Merhaba.
Yeah, I can hear you. Yeah, merhabalar. Besim, are you there? Besim?
Hi, hello.
Yeah,
Hello.
okay.
I would like to change my background. Do you know how can I change it?
You need to go to the
Ayarlardan değiştirebilirsiniz hocam. Duvar kağıtları bölümünde.
Oraya nereye gireceğim?
Ayarlar diyorsunuz hocam. Bu ekrandan değil, ilk
Evet.
açılan ekrandan girmeniz gerekiyor.
İlk Zoom ekranından.
Sorry Besim.
O zaman kapatıp mı çıkıp mı tekrar?
Yok, açıkken yapabilirsiniz. Normal sizin olduğunuz ekran sağ üst köşede settings veya ayarlar hocam.
Bulamadım Mustafa Bey.
Esra Hocam, bu mikrofonu açma ve görüntü kapatma yerinde hani stop video var ya, oradaki ok işaretine basın lütfen. Orada basınca stop video kısmında orada çıkıyor. Virtual background diye.
Bir saniye şöyle ben. Benim altta bu security, participant chat, share screen, record, reaction, stop video. Evet, onu
Evet,
buldum.
orada
Video
üstte
settings'te, settings'te.
Yok, hayır, onun iki üstünde choose virtual background var.
Evet, oradan. None. Tamam, oldu. Kusura bakmayın. Eski bir sunumdan kalmış bu da. Okay.
Welcome, Dr. Esra Uzerçelik, and I'm Dr. Zeynep Balat. I will be really happy to introduce you. And Professor Dr. Esra Uzerçelik is coming from Turkey. Dr. Uzerçelik graduated from Faculty of Dentistry, Ankara University in 2001. She received a PhD degree in restorative dentistry from Ege University in 2007. She has a diverse experience in dental education by giving many theoretical and practical courses in Süleyman Demirel University and İzmir Katip Çelebi University. She received the Associate Professor title in 2012 and Professor title in 2018. She served in various administrative positions at different universities, including Vice Dean of Faculty of Dentistry, Head of the Department of Restorative Dentistry, Erasmus Coordinator, and Farabi Coordinator. Her research interests include aesthetic dentistry, composite restorations, caries risk assessment, adhesion, clinical trials, and digital dentistry. She has authored or co-authored many publications and has given many presentations at national or international specific meetings. She is a member of International Association for Dental Research, MI Turkish Board, and Turkish Association of Restorative Dentistry. She has a good level of English. She is married and has a son. The topic of her speech is Vital Tooth Bleaching, the Key to Success. Now the chair is yours, Dr. Çelik. Thank you.
Thank you very much. Good afternoon, everybody. It's a great pleasure for me to make a presentation in this organization. And before starting my presentation, I would like to thank to Knightsbridge Academy for their kind invitation. Okay, today my topic is vital tooth bleaching, the key to success. But first, I think I have to share my screen share and yes. Also,
You need to click on share screen.
yeah, on share screen. No, it's not. Can you see?
Yes, we can see. You can see. Yeah.
Okay.
Yeah. Okay, it's better.
Okay. Today our topic is vital tooth bleaching and the key to success. And the concept of looking better is gaining wider acceptance throughout the world. And in dentistry, to provide patients to look better is achieved by giving them better smile. There are different ways to make the smile better, but the most minimally invasive and cheapest way is to give them wider smile with tooth bleaching techniques. Okay. And yes, tooth bleaching process is an old technique. The tooth whitening process began around 4,000 years ago in the ancient Egyptian, and they used their whitening paste from ground cobblestone mixed in wine vinegar. White teeth symbolized wealth and beauty at that time, and ancient Romans used urine for whitening their teeth. People preferred barbers for the care of hair and their teeth during the 17th century. The barber would apply an acid for whitening. Yes, this acid whitened teeth, but also it eroded tooth enamel, so it was abundant. And the search for ideal agent for whitening of discolored teeth began in the 1800s. Oxalic acid, chlorine, and cyanide of potassium nitrate were first employed to remove stains caused by metallic restorations. And in 1884, the use of hydrogen peroxide was introduced by Dr. Harlan. In the 1900s, chlorine, superoxole, and sodium perborate were used for intracoronal bleaching, and in the late for vital teeth, first hydrogen peroxide was used in a solution form. In the late 1960s, a home bleaching technique was discovered by Dr. Bill Klusmuir, an orthodontist. He prescribed an oral antiseptic, Bilioxide, containing 10% carbamide peroxide with a custom fitting tray. Yes, this gel was first described to improve gingival health, but the teeth were also widened, and in 1992, Dr. Haywood and Heyman described this technique as a night guard vital bleaching technique nearly 20 years later. Then over-the-counter products were put on the market in the United States. They include lower concentrations of hydrogen peroxide. And different light sources have been used to accelerate the whitening process. As in recent years, two important concepts have come to the fore in dentistry. The first one is minimally invasive dentistry. According to this concept, treatments are performed with minimal intervention to dental tissues. And during this period, the demand for bleaching treatments has gradually increased among the society because bleaching is the most minimally invasive method to improve the discolored teeth. The second is aesthetic dentistry. And unfortunately, the star of this concept is ceramic restorations. And don't forget this, it's very difficult to obtain ceramic white with bleaching. So the demand for bleaching has relatively decreased during this period. Yes. Brooke Shields was a well-known actress in Hollywood in 1960s, and she was the symbol of beauty at that time. But as you see, her teeth were white, but in natural shape and form. This smile was also acceptable at that time in even Hollywood. Aesthetic concept has first changed in Hollywood. Today, we come across ceramic restorations when we search for whiter smile in Hollywood. But nowadays, all we are well-known people thanks to the social media. And a wide and beautiful smile is very important for all of us. And we encounter ceramic restorations when we search the internet with keywords wider smiles. But we cannot achieve such white teeth with bleaching because we just lighten the shade of the tooth. We do not try to make any change in the structure or translucency of tooth with vital bleaching techniques. At the end, nowadays, all we want to have wider and brighter teeth because wider teeth is an indicator of youth, health, and physical attractiveness. But how we can widen the teeth?
Göndereceğiz inşallah. Gönderiyoruz abi. İnşallah. Seninkini gönderdik. Ha.
Okay, let's listen it. How the mechanism of the bleaching process.
As carbon peroxide or hydrogen peroxide penetrate the enamel prisms in your teeth to get to discolored molecules in your dentin. Oxygen molecules from the bleaching agents break the carbon bonds of the discolored molecules. The oxygen molecules spread, whitening the entire tooth. As a result, you're left with a brighter, whiter smile.
Yes, first hydrogen peroxide and carbamide peroxide break down to the oxygen, then this oxygen break down the long chain chromogens to short chain molecules, and this leads to whiten the teeth. Yes, what's the difference between whitening and bleaching? Tooth whitening is any process that lightens the color of tooth. Whitening may be achieved by the physical removal of the stain or a chemical reaction to lighten the tooth color. But bleaching is the chemical degradation of the chromogens. And yes, there have been very important developments in the scientific fields in recent years. On one hand, we're planning to go to the moon and then to Mars. We're planning to establish a new civilization on Mars, and numerous developments are also taking place in the field of nanotechnology, regeneration, and artificial intelligence. Then, what's the situation in bleaching? What changed from past to the present in bleaching therapy? In the other words, where we are. Today, we still use hydrogen peroxide or carbamide peroxide as a bleaching agent. The application modes are in office and at-home bleaching, and the light activation accelerates the bleaching process. And yes, initial tooth color is important, and it's hard to bleach dark shades. The well-known complication is tooth sensitivity in vital tooth bleaching still. And yes, there can be relapse within time in the bleaching results. And to the best of our knowledge, bleaching agents are safe when they are used under the supervision of dentists. And what are the indications and contraindications? All discolored teeth, light tetracycline staining, fluorostate without enamel loss, pink-brown porphyria discoloration are the basic indications, but also there are some contraindications. And excessive enamel loss, deep cracks and fractures, pregnant and lactating women, peroxide allergy, unrealistic expectations, and very large pulp chamber, temporomandibular joint disorder, dentin hypersensitivity, and smoking and use of tobacco products are contraindications of tooth bleaching process. And we have to give attention to all bleaching steps, and the bleaching steps are first to make a realistic plan, to employ the right technique, to manage the complication, and to maintain the bleaching effect. First, we have to make a treatment plan, and during making this plan, we have to consider patient expectation, age, discoloration type, tooth evaluation, oral hygiene, smoking, and the type of technique. Yes, dreams and reality. Sometimes the expectation of the people significantly affect their satisfaction with the treatment. No matter how well we do the treatment in patients with very high expectations or those who want ceramic white, this may not satisfy the patient. Initial shade, enamel opacity, and thickness are very important when predicting the outcome. For example, in our first patient, the initial shade was light and the teeth were more translucent. But in the patient, in the second picture, the initial shade was darker and the teeth were more opaque. And in which the treatment results satisfied the patient more? The answer is in the second patient. Why? Because the initial shade was lighter in the first patient. In the first patient, the initial shade is lighter, and the teeth were more translucent, so the result was not very striking. But in the second patient, the teeth were more opaque, and also the initial shade was darker. So at the end, the teeth were perceived wider. And age is a factor affecting the treatment success. And as people are getting older, the enamel tissue becomes thinner and dentinal tubules become occluded. So the bleaching process becomes difficult. In addition, the average age of the patient is approximately 30 in previous studies. And so we have limited knowledge on the bleaching efficacy of our current systems on elder people. However, in the near future, we will have more elderly patients who apply to our clinic for bleaching treatment. And what about patients younger than 18 years of age? In general, we do not recommend bleaching procedures for patients younger than 18 years of age because of the risk of patients not being able to cooperate adequately, and they can also have more tooth sensitivity. So we prefer to delay the treatment to older ages. But if the patient has severe pathological discoloration, then it may need to be treated before the age of 18. And what is the ideal age for tooth bleaching? According to my clinical experience, I think ideal age is between 25 to 35 years old. And coloring agents are very important also. The effect of coloring agents on treatment prognosis is very, very important. And the smoking is known as a contraindication for bleaching. However, too much discoloration may be observed in these patients. Yes, the ideal is to quit smoking, but this is not always possible for our patients. And so these situations has led researchers to search for alternative methods for smoking patients. In recent years, new research have been published on the prognosis of bleaching in smokers. And according to this research, tooth bleaching may be also successful in smokers, but they can need more follow-ups. They may need dental prophylaxis in these follow-ups compared to non-smokers. And the color relapse increases when the patients use coloring agents during or after bleaching. Yes, medications are really important, especially some medications and mouthwash. They can cause discoloration on the teeth. First, some patients can apply to our clinic with rapidly developing tooth discoloration. In this case, we have to question the patient in terms of medicines and mouthwash they used. And secondly, we should inform the patients to whom we apply bleaching therapy that these drugs and mouthwash can cause discoloration, so they have to avoid to use these drugs or medications during bleaching therapy. And tooth discoloration severity affects the bleaching efficacy. Both bleaching agents show better action on dark teeth than light teeth, I mean both in office and at home bleaching techniques. But the final shade was darker in dark teeth versus light teeth after the same bleaching period. So we have to apply the bleaching therapy probably longer to darker the teeth with darker shades. And yes, good oral examination is very important. Fractures, cracks, and wear should be evaluated before the treatment because this can cause tooth sensitivity, and deep wounds should be covered. For example, incisional surfaces should be covered in adhesion lesion with an bonding agent. In addition, the choice of bleaching agent and application time in the treatment should be planned according to these properties of teeth, because it increases the risk of tooth sensitivity. Oral hygiene is very important in many aspects. It affects the efficacy of the whitening process, and relapse is generally faster in patients with poor oral hygiene. As we are talking about success, what is success? First, we have to define the success in bleaching therapy. Yes, what are our goals? First, we want to reach B1 shade. However, it's not always possible in bleaching therapy. Yes, it's ideal to avoid all complications, but managing the complication is also an ideal result. Yes, and we have to try to protect the final shade as much as possible, and we have to make some suggestions to our patients to reduce relapse in color after the treatment. In the bleaching therapy, yes, we have to whiten the teeth, but also we have to try to eliminate the shade difference between central incisors and canines and the cervical and incisional area. The elimination of this difference will allow teeth to be perceived wider. The concept, which known as shade, consists of three dimensions: hue, value, and chrome. And in bleaching process, the hue may not change after the process. In other words, if the tooth is in A3 shade at the beginning, it cannot be bleached until B1 shade in each case and can remain in A1 shade in A series. The biggest change occurs in value and chrome in bleaching therapy. And sometimes, although too much widening is observed, the patient may not be satisfied with the results, such in this case. The reason for this is that the translucency of tooth does not change much during bleaching process, and the tooth preserves its natural structure, but its color widens just. In this patient, we got 7 to 10 shades improvement, but at the end of the treatment, the patient was not very satisfied. Yes, and how many visits should we apply the bleaching gel? Also, this is the commonly asked questions to us. Ideally, continue bleaching until you reach B1 shade. But we may not reach this color in each patient. In this case, an other criterion is to continue bleaching under there's no difference between the two visits. Yeah, okay, then we want to continue to bleach the teeth. How many sessions can we apply the bleaching gel maximum? According to ADA, Council on Scientific Affairs, for at-home bleaching, 6 weeks applications have been reported in the literature. And also there are 3 to 6 months of applications in cases such as tetracycline. Application of 1 to 6 visits has been reported for the in-office systems, and generally very good results are obtained in an average of 3 visits. I think this is very important in bleaching therapy. The bleaching process should not be introduced as a single visit therapy because this will increase patient expectations and will negatively affect the prognosis of the bleaching therapy because we cannot get a good satisfactory results in each patient at just one visit. This is very, very important to balance the patient expectation. Yes, and also discoloration type is important because it's hard to bleach some discolorations like severe tetracycline and severe fluorosis cases and also metallic restorations, metallic discolorations. As bleaching techniques are divided into 4 professional techniques in office, in other words, and also under supervision of dentist bleaching, at-home bleaching, over-the-counter products, and non-dental techniques. And which one, in office or at home? Unfortunately, both have some advantage and disadvantage. And also the advantage of in-office bleaching applied by dentists protection of soft tissues faster than at-home technique. The advantage of at-home systems, low concentration gel, we apply low concentration gel, shorter treatment time in office, generally low tooth sensitivity is produced and low cost. The disadvantage of in-office bleaching, high cost, long treatment time in the office, high concentration gel, and high tooth sensitivity. And the disadvantage of at-home bleaching, the result depends on patient cooperation. It can disturb the taste also because it releases into mouth. Gel may release into the mouth, yes, gingival sensitivity and longer treatment time. Yes, the other alternative is a combined therapy. It includes 1 visit in office and 1 to 3 weeks at home bleaching. Yes. The active agents used in the office bleaching system are hydrogen peroxide and carbamide peroxide. But also there are some alternatives like non-peroxide gels in the dental market, but they're not commonly used materials. And which ingredients are important? Active agent, concentration, pH, activator, and desensitizers and remineralizants are important. Yes, activators generally determines the speed of bleaching, and in bleaching systems, chemical activators are generally used, but also heat, sometimes laser and high power lamps, low power lamps, and ultraviolet light are used as an activator. In office bleaching, we use high concentration or low concentration gels nowadays. High concentration gels include 30 to 40% hydrogen peroxide. They're effective systems, they're conventional systems, and generally all products have similar performance, but there can be difference between the different brands in terms of speed of bleaching process depending on the activators they use. And the other alternatives are low concentration gels, and they are relatively new products in dentistry. They include 6 to 25% hydrogen peroxide. But their effectiveness depends on their activator. And in the dental market, all low concentration products have different activators, and generally they're patented to this brand. So the products include the same concentration of hydrogen peroxide, may show completely different performance, and we could not predict it before use. In other words, we can predict their performance after we use it. Yes, is light activation required? Regardless of the light type, it was observed that the use of light source did not increase the whitening efficacy of low and high concentration gels. Generally, in this situation, I advise the operators to use light activation if the manufacturer claim them to mandatory use it. But if it's not mandatory, I advise the operator not to use it, because probably it would not have a beneficial effect on the bleaching process. And the stages of in-office bleaching are oral examination, selection of bleaching agent, selection of technique, shade assessment, soft tissue protection, application of gel, number of visits, and recommendations to patient. Yes, before the shade assessment, the tooth surface should be clean. This is important. And the shade may be determined with a Vita scale or with a dental spectrophotometer. In my clinic, I generally use dental spectrophotometer because to take an quantitative data. And initial dental photos should be taken. This is very important because generally patients forgot their initial shade. This is important for documentation. And you may use daylight, artificial daylight, or white balance mode during taking photos. Yes, the other stage is protection of the soft tissue. Yes, you have to protect your and also your patient's glasses, so you have to wear glasses. You have to wear glasses. You have to use a cheek retractor and tongue retractor during bleaching system to protect the cheeks and tongue. And the surface of teeth should be clean before the application of gingival barrier, gingival dam. Generally, it's a light cured material. You have to check its tip first, and you have to apply it on gingiva next to the tooth. And also you have to overflow this gel of nearly 0.5 millimeter to cervical enamel. There shouldn't be any gap between the gingiva and tooth. After the application, you have to check it. Carefully and light cure it according to the manufacturer's instructions. And then check the stability of the gingival dam. But if you use light activation, in this situation, you have to cover all soft tissues because light activation generally produces heat during the treatment, and this heat can damage the soft tissues. And then the application of the gel. Yes, you have to carefully follow the manufacturer's instructions during mixing and during the application. you have to control the resistance of the tip before the application. Apply the gel onto the buccal surface according to manufacturer instructions. And you have to wait for a while according to manufacturer's instructions. After the first cycle has finished, remove the gel from the tube. If you're gonna apply a second cycle, in the situations I generally do not wash the tool surface if there's no sensitivity in the patient. But if there's sensitivity, a mild sensitivity, I wash the surface of teeth. Then I continue to apply fresh gel in second cycle. And in some cases, in office bleaching cases, yes, we used a high concentration gel in this patient and we get 3 to 7 shade improvements in 2 visits in this patient. Also, we applied a high concentration gel in this patient. We get 3 to 10 shade improvements in 3 visits in this patient. Yes, in this patient, we first bleached the upper arch. You can see the difference between the bleached and unbleached teeth, and also we use the low concentration gel in these patients. We get 7 to 10 shades improvements in 3 visits. And another low concentration gel case, we get 4 to 8 shade improvement in 2 visits in this patient. Also, this is another case. We get 3 to 10 shade improvements in this patient in 2 visits. In each visit, we applied the gel according to manufacturer instructions, 20 minutes, but we applied 3 cycles in this patient in each visit. And another case, we get 3 to 10 shade improvements in 2 visits. And in this patient, we get 7 to 10 shade improvements in 2 visits. As you see, we applied the bleaching system generally at least 2 visits, especially to get good results in canines. According to my clinical experience, I can get these results. If the initial shade is A2 in the patient, then 1 visit is enough to get A1 or B1 shade at the end of the bleaching process. If the initial shade is A3, then generally 1 to 2 visits are needed to achieve to get A1 or B1 shade. If the initial shade is darker than A3, then 2 to 3 visits are needed to reach A1 or B1 shade. And the other technique is at-home bleaching technique. Treatment stages are similar: oral examination, selection of bleaching agent, preparation of tray. In this patient, we have to prepare a tray for bleaching, and application of gel, number of visits, and recommendation to patient. As we have to take shade with a dental spectrophotometer or with a scale, then take initial photos. We have to prepare custom fit trays in these systems. We have to first take impressions and get a cast model. Then we prepare reservoirs with the block-out material. I prefer generally scallop design in my trays. The patients should place the gel in the reservoirs, into the reservoirs in this method. We generally prefer the trays in 1 millimeter thickness, but if there's a bruxism in the patient, then the operator may prefer 1.45 millimeter trays. First, we get an impression from the patient, then prepare a cast model. You have to trim the model. The model should be parallel to the floor. And then the operator should apply blockout material onto the buccal surface of teeth in 0.5 millimeter thickness. Yes. Light cure the blockout material according to manufacturer's instructions. Remove the oxygen inhibition layer, and then you're gonna apply the tray onto the model with a vacuum device. After it cools, remove it and remove the excessive parts. After you prepare the tray, you have to check it on the model. There shouldn't be any gap between the tray and model. If there's a gap, you have to adapt it with a flame and water. There shouldn't be any gap. This is very critical issue. Yeah. Then you have to show the patient how to use the bleaching agent, how to apply the bleaching agent into the tray. It is beneficial for your patients to try it with the operator. And the excessive gel should be removed with a toothbrush. Then, after the bleaching process, the patient should brush their teeth and should wash the tray with a toothbrush. We use 10 to 22% carbamide peroxide or 3 to 10% hydrogen peroxide as in the at-home bleaching. And when we use these systems for 2 weeks, generally we get 3 shade improvements in light shades, we get 6 shade improvements in medium dark shades, and we get 9 shades improvements in dark shades. And when the initial shade of the tooth is darker than A3, generally more than 2 weeks are required for at-home bleaching technique. And which one, at-home bleaching or in-office bleaching, is according to my clinical experience. If there are tooth cracks on the tooth, I generally prefer at-home bleaching in these cases. If the patient has shorter time for bleaching process, I generally prefer in-office or combined therapy. If the patient has less time for in-office treatment, then I prefer at-home bleaching or combined therapy in this patient. And translucent enamel syncretic dentin, in this situation, I prefer at-home bleaching or combined therapy. And in severe discoloration cases, I generally prefer combined therapy. Yes, this is a case I applied combined therapy in this case, 1 visit at home in office bleaching and 2 weeks at home bleaching. And we got 10 to 12 shade improvements in this bleaching. I generally love to apply a combined therapy in bleaching process. And the other technique is microabrasion. In microabrasion technique, we use generally paste containing hydrochloric acid to abrade the subsurface porosities together with stains that cause discoloration, and we use this technique generally in hypomineralization lesions like fluorosis case. And the other technique is atom bleaching technique, but over-the-counter products. They are cheap, easily available, and can be applied in a short time. They are uncontrolled use, but they have some disadvantages. Their uncontrolled use creates sensitivity and gingival damage, and the desired whiteness may not be achieved when the patients are used these systems. These systems sometimes cannot satisfy the patient. Yes, we can get nearly 2 to 4 shades improvements with over-the-counter products. So we generally advise our patients to use them in light-colored teeth, and also we can use these over-the-counter products in combined therapy with in-office bleaching technique and in the maintenance treatments. And some at-home bleaching cases. In this patient, we use 10% carbamide peroxide for 2 weeks, and we get 8 to 10 shade improvements. And another case, that applied 10% carbamide peroxide for 2 weeks, we get 7 to 8 shade improvements in this case. This is an over-the-counter product case. We used an over-the-counter product for 10 days, and we just get 4 shade improvements in this patient. And this is a fluorosis case. We used microabrasion with in-office systems. In office bleaching, we get very acceptable results for the patients. And this is another dental fluorosis case. We used microabrasion technique with at-home bleaching technique for 3 weeks, and we get very good results in this patient also. Yes, when we're making a treatment plan for our patients, we have to consider this principle. Generally, 1 visit in office treatment equals to 1 week at-home bleaching application, and also it equals to 16 days over-the-counter products application. And yeah, there are some also, we can encounter some problems during bleaching process. What are they? Tooth sensitivity, gingival irritation, and color relapse are mainly encountered problems during bleaching. And tooth sensitivity is an important, I think, complication, is a commonly encountered complication. It occurs because peroxide can reach to the dentin and pulp, and it can produce reversible damage in the pulp. And generally, higher risk exists for higher peroxide concentrations, unfortunately. And what can we do for this problem? First, we have to prevent tooth sensitivity. Prevention is important. We have to make a good oral examination and cover the exposed dental surfaces. This is very important. Also, the other alternatives are to use of desensitizing toothpaste 2 weeks before bleaching, and use of desensitizers nearly 30 minutes before bleaching. Generally, these desensitizers include potassium nitrate. But if the hypersensitivity occurred after bleaching, then what can we do? We can apply potassium nitrate, fluoride, casein phospholipid, laser, or painkillers to our patient. We can prescribe painkillers. But don't forget this. All these techniques cannot eliminate all hypersensitivity. They can just reduce the hypersensitivity. Generally, hypersensitivity heals within time by itself. And the other alternatives, interrupting treatment for a while, re-examine the patient, and also solve the problems in the patient that causes tooth sensitivity, changing the treatment protocol, and if the sensitivity is very severe, anesthetize the patient also. Teeth should be brushed with warm water and a soft brush to prevent a hypersensitivity. Very hot and cold food and drinks should be avoided during treatment. And also bleaching agents should not be used longer than recommendations to prevent the tooth hypersensitivity. Yes, relapse. That can be relapse in bleaching result. Relapse in color after 1 to 2 weeks after the bleaching application can be seen. It's normal. It's due to rehydration and also remineralization. But also within time, due to use of coloring agents, relapse can be occurred after the bleaching treatment. Generally, we advise operators to polish the teeth and to prescribe their patients remineralizing agents at least for 1 month after the bleaching to prevent the color relapse in earlier times. But there can be relapse within 2 to 4 years, and in this situation, generally 1 to 2 days at home or 1 visit in office application can be enough to get good results. And also over-the-counter products can be used in this situation. And what is the feature of bleaching? Yes, in the feature, probably we're gonna use artificial intelligence also for bleaching process. In the other words, the bleaching process will be more individualized. Yes, this is a new device. This automatizes the process. Yes, the trays are specific for the patient, but we can easily prepare it. And the gels are automated, mixed. And are heated by the device. And we use freshly prepared gels. And gel exposure to all teeth surfaces. With the help of patented soft tissue isolation, we can arrange the concentration and duration. Probably we're gonna get good results in 1 visit. It can be applied by hygienists. Yes, as a conclusion, I think in an operative manner, bleaching therapy is relatively easy method, but to manage the treatment is very important to get successful results in bleaching therapy. The operator should make a proper indication. To balance the patient expectation is very important, and to select proper technique and also material is critical in bleaching process. Attention should be paid to the details and technique, The operator should know the endpoint and should manage the complications. Also, suggestions should be made for maintenance. After all, we can get very good results in bleaching therapy. Yes, by this way, I've finished my presentation. Thank you very much for your attention.
Thank you. Thank you for your presentation, Dr. Uzer Çelik.
Thank you.
Thank you for your nice presentation, as usual. Any question to Professor Esra? Uzer Çelik.
Yes,
there are few questions in the chat box, but
Chat box, some
yes,
questions.
but they are about orthodontics, so which is the previous presentation. So I think your questions will be with the next session.
I think there's a question. I can see a question about whitening process, lasers. Okay.
Mikrofonunuz kapalı olabilir mi?
Yeah.
Can you hear me?
Yes, we can hear you now.
Okay. Okay. I saw a question about whitening in the chat. What do you think whitening with diode laser? I think. Do you advise it? Yeah. Okay, then I can answer it. Yes, lasers also are used for tooth whitening. I think, yeah, to apply the gel with laser, yes, has some advantage, but it may increases the speed of the treatment. But I think the final success will be equal to apply it with or without laser. It may just increase the treatment periods. It may speed the bleaching treatment. I generally use, I don't use light activation in my clinic because they also have some disadvantages. They, yes, produce very good results immediately at the end of the treatment because of also rehydration, because heat produces during light activation and this causes rehydration onto surface. But after generally 2 weeks, there can be a evident relapse when you use light activation. So in my clinic, generally, I don't use light activation, but you can use also. It's up to you. But I think it doesn't have very beneficial effect on the bleaching efficacy. Sesim geliyor mu?
Yes, we can hear you.
Okay. Can you hear me? Okay.
Thank you for your presentation, Dr. Çelik.
Okay. Also, I again would like to thank to you for your kind invitation.
Thank
It's a great pleasure for me to be here. Thank you.
It is our pleasure. Thank you.
I think it's Dr.
Okay, in the next session, we will be started in 5 minutes, dear colleagues. So during this 5 minutes, we will arrange Professor Altay Uludamar. Okay.
Should I present the Dr. Uludamar now or?
Yeah. It's better to wait a few minutes.
Okay, okay. I'm waiting.
Everything should be on time. Altı hocam şeyi açabilirsiniz. Prezentasyonu. Hı hı. Your microphone is switched off.
Can you see the presentation first page?
No, we cannot.
Will you allow me to share my screen already?
Yes. Okay, it works. Okay.
Okay, can you see the print?
Okay, thank you. Dr. Zeynep, we can start with your introduction.
Okay, welcome, Dr. Uludamar.
Thank you very much.
Thank you. Dr. Uludamar was born in 1966 in Ankara and graduated from the Hacettepe University, Faculty of Dentistry in 1988. After graduation, he worked at the Prosthodontics Department of Selçuk University in Konya as a research assistant. He continued his studies at the University of London, Eastman Dental Hospital, Department of Prosthetics, and received his Master of Science degree in prosthetic dentistry in 1993. Dr. Uludamar submitted his PhD thesis titled An In Vitro Investigation to Evaluate the Influence of Different Surface Preparation Methods on the Bone Strength of Two Composite Resin Luting Cement to Yttrium Stabilized Zirconium Oxide Ceramic, and gained his PhD degree in 2007. In 2012, he became an associate professor in prosthodontics. He worked in Medicodent multidisciplinary dental clinic in partnership between 2008 and 2017 in Ankara, while he was also acting as a clinical consultant for Evoklar Viva Dent Turkey. In 2016, he took part as a founding member and lecturer of Cappadocia University Dental Technology Vocational School and lectured and trained dental technician students on dental laboratory, technology, and prosthodontics. He has been elected to lecture international students in Cyprus Health and Social Sciences University since fall 2017 academic year, and had become professor in prosthodontics department at the same university. He is the author for many national and international articles and has been lecturing and training the course participants on aesthetic dentistry and dental materials. Dr. Uludamar is the co-founder of Dental Dente Private Dental Clinic in Istanbul, which is a multidisciplinary dental clinic with incorporated training facilities for dentists. The topic of his speech is "Beauty is Power, a Smile is Its Sword," quoted by John Ray. Now the chair is yours, Dr. Uludamar. Thank you.
Good evening to you all. Thank you so much for the nice introduction. It's nice to be here. Thank you for the invitation. I'm very glad to be part of this first international online symposium of Knightsbridge Academy. I didn't know I was going to be introduced nicely as such, so I already prepared some introduction for myself too. So quickly, as I won't be able to change the presentation now, I'll quickly also go through introducing myself. Okay, oops, sorry. Okay, as I was introduced, I graduated from the Hacettepe University. I'll quickly pass this part for you. And then I took a position in Konya Selçuk University as a research assistant. After that, I went to London to study at the Eastman Dental School, University College of London. And afterwards, joined the Cyprus Health and Social Sciences University, and currently I am also lecturing in full capacity. When I say in full capacity, of course it's not full time, but I allocate some time of my clinical and also theoretical part, lecturing students in Cyprus. It's quite nice. I've been to actually Dubai a couple of times. I don't know how many times I've been to Dubai over the past years. It's a very nice place. I hope one day I can revisit Dubai. I have really nice, good memories being there. Cyprus Health and Social Sciences University, we have actually very recently did a graduation ceremony. It was yesterday, or the day before yesterday, sorry, and I was there. And it was a great honor for me to be part of the graduation ceremony in Cyprus. We have international students, also local students. And as you all know, due to the pandemic, we have now online courses, online lectures. Hopefully it will change next year, and then we will, as students also mentioned that they really missed sharing time with us, with the lecturers, and hopefully it will change over the coming days. I am a founder of Dental Clinic in Istanbul. This is a multidisciplinary clinic. We have 7 doctors working in our office, and I am actually very happy to be part of this multidisciplinary clinic. It really makes life easy, and then also contribute and boost the quality of treatment, because I was also before in Ankara part of a multidisciplinary clinic. So this is the way I like to work actually. So by having such an office, then I can allocate more of my time on my special interests. And as you can see here, we have pedodontics and surgery, etc. Now, let me just close the tab so I can see the slides better. I'm talking and sharing my, there are some people still admitting. I'm talking and lecturing, I don't know how many years, very long time. And while we are doing that, we also did some studies, as you can see here, in Journal of Aesthetic and Restorative Dentistry. It was, I think, in 2019 or 18, sorry. And you can see the success rate of the veneers 98% after 5 years, and then 91%, sorry, 98% 5 years, 95% at 10 years, and 91% at 15 years. And over 20 years, it was 87%. So this is a really great success rate. And we can actually, with a peace of mind, continue doing these restorations. Currently, of course, the techniques have changed a little bit, and I'm sure if we start a new study after 5, 10, 15 years, the success rates will be even higher. That means the restorations are very successful in years, and we can really have a peace of mind to apply without any hesitation whenever it is possible. And throughout the presentation, I'll give you some hints and tips why we should be actually doing the veneers. It is coming in the following slides. Actually, you will see. This is Journal of Aesthetic and Restorative Dentistry. 2019, we also published the retrospective lens after 10 years results again. So very promising, in line study results. At this study, professionals for the application,
I think there is some connection problems. So,
is it better? Can you hear me?
We can hear you, but very you know, not perfect. So okay, I think problem was sourced from internet connection maybe, but it will be better, I hope.
Okay.
Okay.
How is it now? Can you hear me?
Yes, we can. Yes, we can hear you better,
okay.
Professor.
Okay. All right. Just let me know whenever there is a problem. I already asked all the staff in our clinic to stop using social media, so I won't have any problem with the internet connection. But I don't know. It's in my case, when I check the connection, looks fine, but yeah, there might be a little disruption. I'm sorry about that. Okay, so I've been giving these lectures and courses over the years. I don't know, I really don't remember how many years, how many dental students I shared this courses, and then I shared the information and the knowledge and experience. But it was always good to be with you and with the participants, because I, in the meantime, learned a lot by joining these courses. Still, there is some people admitting. I'm sorry, I have to accept that, I suppose. Okay, yeah, just snapshots from the organizations, lectures, courses. Still continue doing these courses. There will be one in August. And we have done a lot of courses with Vestiaire Academy. Very successful, always nice to work with people in Vestiaire Academy. And again, just for you, a short video how we do these courses. And it's not only veneers, of course. I lecture on digital registration of jewelry. So why objects, but mine ceramic veneer. And during these courses, we actually share these at the end. Hopefully no one point missing, and we get lots of questions. We answer all these questions, so it's exchanging knowledge and experience altogether. One by one, take care of all the procedures, and then showing how to do the preparation, taking impression steps. So the feedback is always very good, and the participants always leave happy and start veneers applications next day in their office, usually Monday, as we do the courses at the weekend. By Monday, they start their new cases. So this presentation, actually just a teaser, of course. The veneers, very wide subject. We can talk for hours. These are a few cases. This slide I always use, without any exception. All these courses, I use this slide during also the student training courses. Just a nice looking restoration doesn't mean a successful restoration. This is very important. Successful restoration should comply all these factors, should comply with the biology of the surrounding tissues. The mechanics should comply about, and then the function is of course the most important. In it is the most important for the patient, but in reality, the function is extremely important for the successful restoration. And a few days ago, I had a patient, a German lady, came to my office. When you look at it, everything looks fine, but the patient is complaining. And this, I always tell the participants of my courses, you know, having a nice looking teeth is not the end result. A successful restoration should have much more than a nice looking restoration. Okay, when you look at it, there is no major problem. The biology is fine. Okay, there are little issues maybe, but no major problem. And this case is actually shared on an Instagram page. It is done in Istanbul, in a very famous, one of the famous, let's say, dental clinics. But patient is not happy. Patient is, she wants to have them even replaced. Why she's not happy? Okay, again, looking at the picture, not bad at all. The shape, and as you can see, the surface texture, etc. It is obvious that a good technician worked on this case. You see, the patient actually described it as it feels like a razor. See these points. Why do we have to do that? Okay, we are not actually fabricating these veneers for ourselves, for our photos, for the comfort of the patient. That should be taken into consideration seriously. Okay. Now, look at the premolars. Do you think there might be something odd? I'll just want to point your attention to this difference, level difference. And patient also complain about the color, because this is probably not enough thickness of the veneer, or not enough preparation. So the color is reflecting beneath the ceramic veneer. Okay. But at the surface value, looking at it, there is not problem. Just looking at it, it would make a nice Instagram photo. Huh? It's due to people admitting I have to accept them. Harmony. Is 21 years old and already have
Excuse me, the video is frozen. Professor, can you hear me? Dear colleagues, sorry for inconvenience, so it will be started shortly.
okay. Can you hear me better now? Connection better?
Yeah, connection is better.
Okay. All right. Sorry about that. I mean, I connected by my phone. It will probably.
Okay, thank you.
It will be probably better. I'm sorry about that. What was the last part you heard? Let me go one maybe step back. Have we seen this case? If you can just confirm. Yes?
Yeah, yeah.
Okay. So, as I said, biology, mechanics, function, aesthetics is very important. In this case, as I said, there are some problems, but on the face value, there isn't a serious problem, it would make a nice, as I said, Instagram photo, but the patient is not happy, so there is a problem. You see those edges is like a saw. This is what the patient said. And the premolars, the level difference with the molar and the second premolar, as you can see, there is a problem with the occlusion, harmonious occlusion. And the color, as you can see, this is due to either lack of preparation or the thickness of the veneer was not properly done. So one of the major problems in restorative treatment is the lost occlusal harmony, as we all know. And many times this harmonious relationship is altered by restorative treatment, or earlier, as I said, through orthodontic treatment. I had one patient today, and she was 21 years old and already had TMJ problems because as a result of orthodontic treatment. The closure was fine, but occlusion is not static, it's a dynamic issue, and just a closure is not enough for a successful functional teeth relation, jaw relation. In the occlusal relation, contacts should be in harmony with muscles and the temporomandibular joint, it's obvious. So what are the advantages of all ceramic restorations? Let's quickly
Sorry, Dr. Altalay, please can you speak louder? The sound is very low.
Okay. Is it better now? Let's test it.
Yes, thank you. Clear.
Let's talk about quickly the advantages of all ceramic restorations. Minimally invasive approach, and then biologic harmony, of course. Then meeting patients' high aesthetic expectations are the major advantages of all ceramic restorations. And believe me, the real showcase of dental clinics are the patients leaving your office with the smile of their dreams. So every patient leaving your office with a nice smile, with a happy restoration, with a smile of their dreams, they act as a walking billboard for you. This is amazing. And every patient leaving your office with a smile like that will bring many more patients. Therefore, veneers, smile design, whatever call it, is really imperative in your success, clinical success. And do your patients know exactly what they want? I asked this question all over the years, and 10 years ago, even 5 years ago, the answer when I asked this question would be, no, they just want a nice smile. But today, thanks to social media, patients know exactly what they want. They even ask you the material, what material will you be using? What is the cementation material, even that, you know? So really, we need to know more about the material. We need to know more about the ins and outs of veneers. As I said, real showcase of dental clinics are the patients leaving your office with the smile of their dreams. Now, all my patients, when they come to my office, they have a history. They have some story to tell. And this patient came with an urgency of having a front teeth, let's say, restored and to have a nice smile, basically. And what we did was only 6 veneers from canine to canine. The patient was about to go to Ukraine, and he wanted to have a nice smile. I don't know why, but we did what he wanted, and he was really happy. And we did that in, I don't know, maybe a couple of days, and the patient is very happy, leaving your office and advertising you all over the places, even in Ukraine. And this is a patient. She is from UK, but another point, not everyone like it natural. We have to respect that. You know, we don't have to force anybody to have, of course, we can advise, but we cannot really, we should not force anybody to have a different color, different shape, and we should mutually agree and then talk about what material to choose, what color to choose, etc., and come to an agreement at the end that would make the patient happy. The patient's happiness, the patient's acceptance is much more important than mine, because I'll be seeing them maybe a couple of hours, a few days, but she'll be seeing herself over the years. Every time when she look at the mirror, she will see and then either appreciate or disappreciate what we have done. When I had this patient, I really had a shock because I never seen anything like this before. It's a sclera tattoo. And when I first saw this patient, his eyes were closed, and when he opened his eyes, I was really shocked. And this patient also has a story. It's a long story. We will talk about these stories more in actual courses. But as a short story I need to tell, this patient had this look, and the restorations in his mouth, they are not just metal, they are dental gold alloy. Patient had quite a lot of good background, hard to believe, but a good background, very good articulation. When I say articulation, the manners, good speech, good speaking. And basically, when I asked why you want to have your teeth to be changed, because there was no problem at all, he said he had a normal girlfriend. That's why he wanted to have a change of his look, change of his life, etc. And I said, it's going to be difficult to change all these things and tattoos in your face. And to be honest, the previous, the look on the left probably suits him better than the look on the right, but it was his wish. It was what he wanted. So we gave him what he wanted, and he's gonna, in time, peel off all these tattoos. I know this is a very difficult procedure, but he's slowly taking steps. So which material? This is one of the most important parts. And the, okay, should I use translucent or opaque material, and when and where should I use it? So this is a dilemma, and this is one of the most important part of the veneer fabrication. Selecting the most suitable material for your clinical case, both shade of the prepared teeth and shade of the final restoration should be taken into consideration. And therefore, effective communication with dental laboratory is the key to successful restorations. So I always say, whatever you do, please have an effective communication, good communication with your dental laboratory, with your dental technician, because we are a team, and without a good dental technician, we cannot achieve a successful restoration. Believe me, please. Okay. And what are the criteria for selecting the most suitable ingots or cap blocks? As we mentioned earlier, the targeted tooth color. So what is the final restorations color? What we achieve for the final restoration? What's our target? And then prepared tooth color is important. And the restoration type, whether we will be fabricating inlay, onlay, veneer, full crown, and the thickness and the depth of the restoration, technique to be applied. Are we going to do a cutback technique? Are we going to use a cutback technique or layering technique? And the cementation material is also important. And we use these shade tabs to decide on the shade of the final restoration. And we also need to transfer the information about the prepared tooth to our dental technician. And as you can see here, let's say the final shade of the restoration A2, this is what we achieve, what we want to achieve. And then prepared shades, prepared tooth shade is ND, which is a natural dye. This is a different shade scale, let's say, and then we need to transfer this. Either we can do it with the shade tab, or we can do the transfer with our photographs. This is also an option. So when it comes to the lab, dental technician can use all of these materials with different techniques. Like if he needs to use medium opacity ingot or block, then he needs to use layering technique, because medium opacity will look too dull, too opaque. So we need to add some layering ceramic to make it alive, to make it more aesthetically looking, more transparent looking restoration. And we can do LT, A2 cutback technique, or HT staining technique could be used. These are all options depending on the restoration, depending on the preparation depth, etc. And what type of material should I use? What is the importance of light translucency? Always the question, always the most difficult part of these courses to understand. It's actually not that difficult. We'll go through briefly. If we have a dark teeth underneath, dark shade, then our options are different. Again, we can use MO, HO, high opacity, medium opacity, or cutback technique, but it is not possible to use high translucency ingot. If we do, we will have failure. Why? Because the underlying tooth color will show, and then, as we have seen earlier in slides, and then we will have a failure. We will not achieve the color we targeted. Okay, we always share a photograph like this with our dental technicians, and we do little drawings, tell them exactly what we want and what to do, what is right, what is wrong, all these explained in detail. So this actually makes us save time, because by doing that, we achieve the results we wanted, and then dental technician understand exactly what we meant. Because otherwise, just telling the dental technicians, just a little bit here, just a little bit there, doesn't mean anything. What is just a little bit? Just a little bit here, just a little bit there. So this is positive, objective data transmitting, and then dental technician can say, oh yes, I can see the problem. Not just a little bit lighter, that's just a little bit darker, doesn't mean anything. This is an implant over superstructure case, but here also we also share with the dental technician what the problems. The front midline needs to be shifted, etc. All these details are shared. So to be able to produce veneers or ceramic restorations, we have two methods. One, pressing. The other one is CAD/CAM technology, as you all know. Actually, there is one hybrid technique too, which I quite like. In that case, you can combine these two methods in one. How do we do that? Your dental technician can do the CAD/CAM procedure on wax, carving on wax with CAD/CAM, and then can do the pressing. So you will have the best of both worlds. All these subjects, of course, very detailed. We can talk, as I said, during the actual courses. I won't bore you too much. This is important. I won't give you too much academic information. But here in this slide, you can see a veneer restoration. We remove only 3 to 30% of the intact tooth substance, while 62 to 72% if we turn that into full crown restoration. This is very important. And this is 4 times more than veneer restoration. So let's put ourselves into our patient's place. What would you like to have? If you can have, of course, I mean, if the indication is correct. Would you rather have a veneer, which is minimally invasive, or a full crown preparation? And the failure rates for full crowns after 10 years, as you can see, 15 for single unit crowns, 30% if fixed bridge abutment teeth, if it's used as for a fixed bridge, then after 10 years, failure rate is 30%. After 15 years, it's 19 to 34%. Again, a little bit of empathy. And initially, from the beginning, you have seen the success rate of veneers. So wherever possible, please choose for veneers rather than full crown restorations. And what are the criteria for selecting the most suitable ingots or CAD blocks? This is the question, and this is a difficult topic. And I know you all think like that, seeing all these variety of materials. But in general terms, we have different light transmission properties in these ingots and in these blocks. So for the successful results, we really need to know the dental materials, and we should be in control of our restorations rather than leaving everything to our dental technicians. So we can of course discuss and get an idea, etc. I'm not against that, but we should first know the material's properties. Like high opacity, when we say high opacity, we mask the underlying tooth. And then medium opacity, as you can see, the line can barely be seen. And low translucency, as you can see again here, we can see much more than medium opacity. And high translucency, we see more clearer. And all these, among all these, later on, the company of material producing companies added one more ingot, one more block type. This is a medium translucency ingot, and believe me, this is one of the most widely used in our clinic, at least. So many admittance. I'm sorry. So we can use these medium opacity 14 veneers, propless veneers, occlusal veneers, crowns and partial crowns, 3-unit bridges up to second premolars, So wide variety of indications covered with these materials. And we should always remember that the system is strong as its weakest link. So if we have a good material, but the layering material is weak, that means the chain is broken. So we have to be careful while we're choosing the right material. Full contour zirconia materials are very popular. We will also talk about these throughout the courses, very popular, and they have really good properties. In recent years, the values of strength and translucency is gradiently combined in these materials. So we have the aesthetic look of almost, not as much as glass ceramics, but at least good aesthetics with the addition of 5 mol yttrium stabilized zirconium polycrystalline to these blocks. So we have the good aesthetics, but also without compromising the strength, durability of the restorations by using these zirconium restorations. I won't go too much in detail, but this is, as you can see, more yttrium addition makes it more translucent, and the less yttrium infusion makes it, gives the material its strength. So we combine the best of both worlds. Then the same thing, dentin zone is the strength, then incisal zone is the aesthetic part. So medium opacity ingots, where do we use them? If we have root canal treated restorations and the color of the tooth is darker and then the preparation is quite excessive, that means if we don't use medium opacity, we will have the darkness of the mouth shining through, and then that means failure for the end result. So we could use medium opacity in such cases. Here, if we have a diastema case, we can use low translucent ingots. These are just examples. Again, as I said, this will be discussed much more in detail. High translucent, usually used in prepless or thin veneers, used for. Okay, low translucent, just you have seen before, could be a diastema closure case, more or thicker veneers. And then we have high opacity and medium opacity when we want to mask the underlying tooth structures. As you can see here, high translucency, much more light translucent. And then we have medium translucency, slightly more, or translucency is less than high translucent ingots. These are all on the same light source. And when we do veneer try-in, as you can see, the cementation material has an impact too. If we use high value cementation material, then we have a much more increased value, the whiter look as the patients in most cases want. Or if we can make it, we can also make it darker slightly. These are all the same restorations, by the way, same material used. Just the using cementation material we can influence the final result of the restoration. These are the cementation materials. We can have dual cure or light cure for veneers. We use most of the times light curing cementation materials. Curing lights are extremely important. Why? Because if we don't have a good curing light, even if we use the best material, as long as we don't cure it properly, it has no value at all. So please invest in accessories such as curing lights. A good curing light is a must in a dental clinic for successful results. Cementation is one of the most difficult part of the veneers. I'll just give you a brief introduction, not cementing veneers, but cementing and the crown, for instance. It's exactly the same procedure, and definitely we will discuss much more on this subject once we have the courses, real courses. And 20-second ceramic etching gel. This is a hydrofluoric acid, 5%. And then we rinse with water spray for 15 seconds. And then we blow dry. Then we use silane for 60 seconds. And then just similar to composite filling procedure, we apply 35% orthophosphoric acid and rinse with water and dry it. And then we apply, I use for almost last 5-6 years, I started using universal bonding agents. Before I had 3-step bonding protocol, but universal adhesives just as good, and the results so far after 6-7 years maybe, no failure at all. The good thing about universal bondings, the thickness of the bonding agent is 10 micron. So we can, with a peace of mind, cure the bonding agents. Before, in the 3-bottle system, we were not curing until the end, the stage. So now we can, with a peace of mind, as I said, cure the bonding agent and then continue with the cementation of the veneers and the crowns and the crowns. And one hint, tip, a small information to take home. If anybody tells you that the veneers are failing and debonding, whatever, as long as you're in enamel, 1 millimeter square enamel actually measure approximately 4 kilogram bonding strength between glass ceramic and the cementation material. Therefore, there is no way, as long as there is no technical problem, no way a veneer can be bond from the mouth. But if there is a technical problem, of course, it is possible. But over the years, I never actually come across in our clinic, the ones I cemented, never experienced such failure. So we applied the cementation material. One of the most critical part is putting a pressure while curing, because if you don't, the hygroscopic pressure will push the restoration up, or in veneer case, will remove the veneer from the surface. Therefore, this is a small, but actually for a success, a large tip. Then we use the floss to remove, before the final curing, remove the excess from the interproximal areas. And then, as you see, achieving a result. And this is more extreme case. I'll go fast here. These are the things actually asked throughout the years, how to mask this discolored tooth. For instance, here we used an opaque mask, but you can also use bleaching, internal bleaching, whatever, it's up to you. Still people coming in. As I noticed, taking pictures, this is one of the tips I just want to share it with you. There will be a lot of tips like this. Mesiodistal dimension of upper central incisor equals nearly mesiodistal size of first lower incisor and half the size of second incisor. So this is just a small tip. Once you get stuck, you can actually have these measures and then use it in your clinical applications. We etched the surface with hydrofluoric acid, then orthophosphoric acid 35%, rinsed, blow dried, universal bonding application, then curing, restoration, silane application, and then here we use the dual curing cementation material. And the end result right after the cementation is quite pleasing, in harmony with the surrounding tissues, and aesthetically is pleasing. Patient is happy, more than happy. I think our time is over. There are much more cases like this. This is an extreme diastema closure case. I'd like to share not just regular cases, but extreme cases like this. So we just want to see, I just want you to see our limitations, what we can achieve with all ceramic restorations. Otherwise, I don't want to advertise myself. Look how good I am, how wonderful works, how wonderful smiles I make. And then I just want to share with you the ins and outs of all ceramic restorations and what to look for, what to care for. And as you have seen earlier in one of the cases, which could be nice looking restoration, but if it's not functional, if it's not in harmony with the biology of the surrounding tissues, then it is not a successful restoration. Yes, I think, I mean, I don't know if we have time, but I don't want to disrupt the flow program.
Yeah, we have few minutes, Professor.
Okay, let's see this case at least. This is an extreme diastema closure. As I said, all these patients, they have stories. This patient is an estate agent, and patient, when he came to my office, he said, well, I am taking lots of people to show the properties, but instead of looking at the properties, they look at my teeth. I'm not happy about that, and I cannot sell properties. They concentrate on my teeth. This is a joke, of course. But he was very unhappy about this look, and it's understandable, really. This was an extreme diastema closure case. He's a smoker, as you can see. The close-up photograph. So what we have done is actually a little bit of illusion also. It includes an illusion. We just shifted from taking from the distal side, adding to the mesial side, taking from the distal side, adding to the mesial side, and then adding on the mesial side of these laterals. We just closed the diastema. So this is the end result. We, as I said, we used some illusions. This is how it looked from the inside. It was like this. And it became like this. The more striking change you will see now, the patient was looking like this. Now, everyone will look at his properties, not his teeth, or maybe some people will look at his teeth too, or his face, let's say. Okay. So it's not difficult to achieve these results if you know the material, if you plan correctly what to achieve. The planning is the most important part. As the time is very limited, I cannot stress out all these topics, but a good planning is more than halfway to a successful restoration, successful result. He has become a handsome man. Okay, this is maybe last case. This is also a very interesting case. Okay. The patient, 17 years old, had orthodontic treatment. As you can see, the spots, she's not happy with the way she looks, understandably. And initially, for this patient, when she came to my office, actually she had implants planned, but patient was scared and she didn't want to go through the implant procedure. And her mother came to me and said, "Doctor, is there anything can be done without the implants?" I said, as I have also daughters, I said, I'll do something and let's see what we can achieve. So we started with a planning first. This is the initial picture. Not happy at all, understandably. This is intraoral. We did first wax up and then mock-up. Transferred the mock-up in the patient's mouth. During the mock-up, we also checked the occlusion, as you have seen. So with the mock-up, already I can see, yes, we can achieve a good look. We can do something about it. And this is the intraoral pictures of the final restoration. Here, just notice that a cantilever supported by a veneer on canine. You won't see it anywhere else. And almost 8 years old, this case, and no problem at all. She's still very happy. So it is possible in the challenging anterior region without implants, a good appearance like that too. You see, canine, veneer, and then cantilever, lateral, but the occlusion needs to be taken into consideration seriously. Okay, this is the anterior guidance checked. So we have no contacts on laterals, with anterior guidance. This is the final restoration. So this is the final look of the patient, and you see even the spots on the way. This is where we started. This is on the right where we ended. So, okay.
Okay, thank you very much for a great presentation, Professor.
Much more cases, but as I said, hopefully we will have a chance to discuss all these cases more. As you know, veneers, very extensive, wide subject. So 40 minutes, unfortunately, this is all I can share with you. Thank you for your attention. And if there are any questions, I'll be happy to answer your questions.
If anyone has a question, you can put in the chat box, colleagues. Thank you very much for your attention. Okay. Professor, thank you very much.
You're welcome. Thank you so much for the invitation. And I hope it will go through, this symposium will go through without any problem, without any internet problems.
Yeah, thank you very much.
Hope to see you all again. Thank you.
Thank you.
Thank you.
Dr. Zeynep, we can continue. So,
Okay.
Andy is with us, I think. Yeah, okay.
Yes, hello.
Okay, hello. Yeah.
Hello.
Yeah, okay.
Our next speaker is Dr. Andy Dragus from Romania. He is dental-alveolar surgeon, implantologist, specialized on dental aesthetics with high emphasis on functionality determined by the ATM and TMJ diagnosis with condylography. His notion of dentistry is a complex and interdisciplinary one. He described himself as, "My specializations help me to combine surgery with dental aesthetics and prosthetics in a unitary whole. Regarding the functionality of the prosthetic restorations, I'm always guided by the anatomy of two TMGs and the entire neuromuscular system in order to avoid any imbalance of the craniomandibular system." The topic of his speech is functional tooth redesign. Now the chair is yours, Doctor. Thank you.
Thank you very much. Thank you very much for your invitation, for kindly introduction. And today I will talk about one of my concepts, and it's 50 minutes. I hope it's enough to share with you my ideas. I prepared for today complex cases, full mouth restoration. We will have a theoretical part, short one, and then we'll start with the cases. And after that, I'm waiting for your questions. I will share the screen now, yes, because the time is short. Okay. Tell me it's okay. Now I will start the presentation. Okay?
Yeah, you can see your screen, but not.
Yes.
Yeah.
One moment, please. So,
Okay,
it's okay,
perfect.
yeah?
Perfect, yeah.
Can I start? Okay. So, why functional tooth redesign? Because when we have big cases with implant, with veneers, like the professor talked before me, it's very important to understand the tooth like an organ and the tooth volume, because the tooth volume is very important, especially in the indirect work with the team, with the dental laboratory and the praxis. And I call this functional tooth redesign because we have the function, and then we have the tooth like an organ, and we redesign everything because the first design was made by nature, by the genetical, everything, by God. Depends how do you think. And it's important to redesign this very, very predictable and very easy. That's why always I'm trying to standardize my work, but unfortunately for the prothetical work, it's impossible to standardize. So I am from Romania. I live in Bucharest. I have my own clinic. I opened the clinic in 2005, and these are my clinics. You have here some pictures, and these are two my websites. You find everything about me, about my work, and about my team. So functional tooth redesign, trying to understand what can be standard in our prothetical work. So this concept, it's a prothetical concept, both functional and aesthetical, because it's very important. 21st century, it's an aesthetical one, but sometimes we have cases we can't achieve a very good aesthetic result. So it's important to integrate in the stomatognatic system the artificial volumes represented by veneer, crowns, and bridges on the natural teeth or on the implants. Can you hear me?
We can hear you.
Yes, but I have.
But the slide.
I don't know what is. No, it's okay. The concept is designed to preserve the balance of the mandibular dynamic and to reproduce the sixth function of the craniomandibular system: speaking, breathing, swallowing, chewing, stress management, and aesthetics. It's okay? You can hear me?
The
We can hear
presentation,
you.
Okay,
Presentation
thank
is
you. It's only checking. Thank you very much. So the functional 2D design concept is based on the condylography and the transfer of all the resulted data from the dental clinic to the dental laboratory. And this is very easy to do it. It's necessary to have only the appliance, the condylograph. And
please,
this
doctor.
concept, it's about teamwork.
We cannot see the screen.
You cannot see the screen. Okay. Sorry. Now you can see?
Yes, we can see your screen.
It's okay now?
Yeah, presentation is okay, yeah.
Okay. So this concept is based on the condylography and the transfer of all the resulted data from the dental clinic to the dental laboratory. It's about teamwork. And in this team, it's also the patient. And the patient now it's very educated. We have the social media, we have everything. And sometimes this is not so easy for us. They want, you know, they want to look like Brad Pitt, like Angelina Jolie, but it's not so easy to achieve this result for them. So this concept is very easy because if you do the condylography, you can extract all the information from the TMG, especially from the condyle about where is the disc. And after that, we will have the 4 parameters. We will have sagittal condyle inclination, we have Bennett angles, we have immediate side shifting and shift angles. And this is very easy to do it. In 10 minutes, you can have everything here. And this is the transfer from the clinic to the laboratory. And if you have this, you have the patient in the lab, you have the patient in the articulator, and it's very easy to do this volumes represented by artificial teeth. I don't know. It's
Please click with your mouse on the presentation. Sometimes it's.
Yes. Okay.
Yeah. It's
okay.
Closed again. Sorry.
Okay. So
presentation is gone.
It's okay. You can see me.
No, yeah, we can see, but we cannot see the presentation.
Okay. I don't know what's happening. Again. Now you can see me?
No, not presentation.
What's happening?
Yeah.
Okay.
Okay.
Now it's okay, yeah?
Yeah.
So.
Yes, we can see now.
Through its functionality, the functional 2D design concept preserved the biology and physiology of the TMG because the TMG is very important. The TMG guided everything, all the movements of the mandibular dynamics, and it's very important to understand these movements. In fact, this concept is, we have 2 treatment plans. We have the clinical treatment plans, and after that we send everything to the lab or to the milling center, depends how do you work, analog or digital. But this treatment plan, it will go in a lab, and it's very important to have all the information in the lab. There are 2 treatment plans, like I said, because if you don't have a good laboratory, if you don't have all the information, we will have an incomplete work. Again, same problem. I'm sorry, I don't know what's happening.
I don't know.
Can you see my presentation?
No, we cannot see. It is PowerPoint or another?
No, it's not PowerPoint, it's Keynote.
Keynote. I don't know why.
I will share again.
Yes, please.
It's going out. I don't know what's happening. Okay. Now it's okay, yeah?
Yes.
Okay. So, why condylography is very important? And what is this condylography? The condylography is realized with the condylograph, and it's it is a digital method to record the movement of the mandibular dynamics and to diagnose the method and to understand the status of the both TMG. After the condylography, we will obtain the settings for the fully programmable articulator and the information about the intracapsular and extracapsular status of the TMG. And it's very important. If you have only neuromuscular problem, you don't have derangement in the TMG. If you have the disc in the bad position, you must know this, and after that you must reposition the mandibular in the new therapeutical position. And in this stage, when you are doing this condylography, you can see everything. After that, we have this information, and these information are in direct connection with the vertical dimension, because the vertical dimension is very versatile, and it's very important to know how you do this. And always when I'm working, I'm going to the centric occlusion, and in the most of the cases, centric occlusion is not the ICP position. It's different, because 90% of the patients have a long centric, they have different bites, and it's important to understand this. And this vertical dimension is very easy to be controlled with the condylography. I will show in my practical presentation. And the anatomy of the 2 TMG is the one that, together with the neuromuscular system, is guiding the dental aesthetics, because its aesthetics is very important for our patient, and also it's important for us, for our business. So patient came in the clinic, and the dentist intervenes or re-intervenes in these organs. More precisely, through preparation, the doctor intervenes in the structure of the tooth and in its volume. And it's very important, because always I'm looking to the teeth like a volume. And then the dental technician must recreate these organs through various techniques and using different materials. We have now a very, very good material, so we can have a very good aesthetic and very good function. So in order to realize a predictable treatment plan, which is functional and aesthetic, it is required that the artificial volumes, veneers or crowns, to be in balance with the both TMG, with the neuromuscular system, and with the occlusal plane, because the occlusal plane is very important. Is negative, is positive, depends how is the anatomy of the glenoid fossa, where is the disc, and we'll talk later about this. The volumes and implantation of the dental organ tooth in the maxillary and mandibular bone are not accidentally. Always I'm thinking, if I have a rotated tooth, I'm thinking, why is this position on the bone? And we'll see, it's very easy to understand. There are in direct connection with the TMG anatomy and with the vectorial direction of the muscle of the craniomandibular system, with genetic information and the skeletal development. Same problem. I'll go again.
I suggest if we open the keynote as a design, and we can change by clicking on the photos in sequence.
Okay, now you can see me?
Not yet.
Not yet. Okay. But the keynote, it's open. You can see me now?
Yes.
Yes,
can you resize this? Yes.
It's okay?
It's okay now. It's in the presentation mode. If possible, to move it into design mode.
Design mode.
Yes, like this. You can.
No.
Yes. You can resize the window to be more size.
Okay. Now you can see?
Yes, you can see, but still a small window. Yes, like this. Perfect.
It's okay?
Yes.
So, what is the standard? What we can have in the treatment plan, prototypical treatment plan? The only standard is the anatomy, and the condylography, in my opinion, is like the CBCT in implantology. If you do a condylography, it's very easy to have the treatment plan, because this is the treatment plan. These 4 parameters: sagittal condyle inclination, Bennett angles, immediate side shifting, and shift angles. And with this, the dental technician on the articulator can realize a very, very functional and aesthetical work. So this was a short introduction, and now we see the case. This is our patient. It's a female, 15 years old, healthy patient, non-smoking, bad aesthetics, bad mastication, halitosis, and changing position 2.1. This was the situation, initial situation. 8 months before she came in our clinic, she realized these veneers in another clinic. And the main reason was to have whiter teeth. And this was the situation after 8 months. And this is the protrusion. You can see why 2.1 is changing, because we have an interference in protrusion. And we will see after condylography, the sagittal condyle inclination values are very low. And this is the interference, and that's why now we can explain why these veneers is changing the position, but it's not the veneers, it was the changing of the root and the tooth. And these are the lateral right from the occlusal, lateral left, occlusal superior view, occlusal inferior view, and this is the CBCT. This is the bone offer for this. We realize this I do in this case is 2 open sinus lifting, put 4 implants, and this is the situation for her. But for today, I prepare only the prosthetical treatment plan, functional tooth redesign. In a case like this, we have 3 stages. We have the prosthetical treatment plan, surgical treatment plan, and then the odontical treatment plan. So we have a lot of stages, we have a lot of things to do, and these very complicated and complex cases. We start with diagnostic condylography using Arcus Digma system. And after that, it's very important to have the centric occlusion for the vertical dimension. And then we recording Facebook from Digma, from Arcus Digma, from Cavocare. And then we transfer all this resulted data from the condylography to the laboratory. And after that, we can realizing the mandibular repositioning in the new therapeutical position. And it's very important how we can do this. After that, we do the impression for functional sequential VAX-UP diagnostic using the data resulting from the condylography. And then the treatment plan is moving to the lab. With blue, we have lab treatment plan. We're realizing in the lab the functional sequential VAX-UP diagnostic. It's very important. We'll talk later about this sequential VAX-UP. And after that, we start to grind, we start to remove. We start with the end, with this diagnostic from the TMG and from the tooth. So we removed all the prosthetical work. We prepare the teeth with using horizontal preparation protocol. It's another protocol for preparing. I have 3 sets for this with Comet company. I'm doing another recording with Facebook because after grinding and taking off the restoration, we change everything and we need to transfer again the cranium position with the Facebook. We realize impression for the temporary and final crowns and veneers, and then we send to the lab. And they're realizing the temporary and final crowns and veneers. Then we fitting the temporary crowns and veneer in the new therapeutical position. And then final crowns and veneers, checking the static and dynamic occlusion. It's very important to check everything. And then fitting the final crowns and veneers. And In a case like this, I prefer to do the second condylography. Yes, and we have the possibility to check the occlusion digital with occlusend measurement from Bausch. So these are the stage for the prothetical treatment plan. Then we have the surgical treatment plan. We treat this treatment, surgical treatment plan. We have the session 2 open sinus lift, left and right at teeth level 1, 4, 1, 5, 2, 6, 2, 7, 2, 6 to 5. I'm sorry. GBR techniques, 4 implants on 1, 4, 1, 5, 2, 5 to 6. And after 6 months, we have put the healing caps. And endodontical treatment plan, we retreat the tooth number 1, 3, 1, 6 to 6 to 5 to 3 to 7. So this is the treatment plan. This is the vision. We have a lot of stages. These are the implants. And like I said, in the prothetical treatment plan, we start always with the condylography. And you have a short movie with this, how easy it is to do the condylography. So this was a short movie with the condylography. In 10 minutes, you finish. It's very easy. And we have here the condylograph. We have the kinematic phase bow from the upper part, from the nose, from gabella. And we have on this, we have 8 receptors. And we have the inferior part of the condylograph. We have 4 sensors. And it's very easy. The sensors, ultrasonic sensors, transmit information to the receptors. And then we start recording like in the movie. And we record the protrusion, retrusion, lateral left and lateral right. Every movement from 3 times, and the software calculate very exact everything. Here you have a short movie with protrusion from this patient. This is lateral left and lateral right. And then after recording all the movement, it's very important to have the centric occlusion. And in the software, it's very easy to guide the mandible to put the both condyle in the centric position. And this is the starting point for the occlusal concept. And you can do this very easy with Arcus Digma. It's a very simple things. You move, you have this right and red and black cross, and you guide it very easy and slowly the mandible until the cross are in the middle of the circles. And then we have the rapport for the condylography. And this is the treatment plan, the prothetical treatment plan. We have everything here. We have the right TMG, we have the left TMG. We can see here on this trading, we have some interference, we have some neuromuscular problem, but we have the both disc in the right position. And let's talk about right joint. We have sagittal condyle inclination 18.2 degrees, and on the left we have 18.2. So this patient, it's a patient with a eminentia like this. So let's say 45, it's the medium, but we have 18. So this patient, when he's starting to move the mandible, when she chew, she goes direct in horizontal. So that's why it's important to know. We have Bennett angle on the right, we have 4 degrees, on the left 4 degrees. So this patient, it's symmetrical. It's a good patient for us. We have immediate side shifting left and right 0 degrees and shift angles 20 and 20. So the case is easy. Now we have this information, we have everything, we know the limitation and the specification of the cases. And all this information goes in the lab, and the laboratory programming the articulator. It's very important to understand what is the articulator. Articulator, it's a mathematical system and it's very, very exact. And this is what it means, all the 4 parameters. You have in the left, in the image, you have sagittal condyle inclination. We have the sagittal condyle inclination, and the sagittal condyle inclination, it's a vertical. We have the eminentia here, yes, and it's in direct connection with how is the eminentia and how is the glenoid fossa. And then we have Bennett. When we are going to the left, we have Bennett on the right. And the Bennett, it starts to be horizontal. It's a combined movement, vertical and horizontal. And in the horizontal plane, we have 3 parameters. We have Bennett angles, we have immediate side shifting, and we have shift angles. So in the vertical, we have sagittal condyle inclination, and in the horizontal plane, we have 3 parameters: Bennett, immediate side shifting, and shift angle. And it's very important to understand these plans. After that, these parameters will be configured by the dental technician in the dental laboratory. After programming the articulator, we will have the real mandibular dynamics of the patient. And this is the treatment plan. It's very easy to do it. In other words, protrusion, retrusion, lateral left, lateral right, intercast position, medial left, medial right, set in the articulator correspond to the same movement in the situ. And then it's important to understand this mathematical system, the articulator, fully programming articulator. It's important to have also anterior programming, because there are a lot of articulators on the market, but they don't have anterior programming. And here you see Protarevo 7 from Cavo. You see it's a complete system. You have the posterior and also the anterior programming. These are the posterior capsula, and here we're programming everything, all the 4 parameters, and also the software when we are doing condylography, recording everything, and they give us anterior programming. And this is very important, because if we are doing condylography and the dental technician don't have this anterior programming device, it's not like in the mouse. The movement, it will be different if he uses only the 0 degree anterior guidance. So now we extract everything from the anatomy and we transfer this to the lab. The lab first we start with the faceball position. We start to maxilla. It's very important to put the maxilla in the right position, because a model, you can put a model in a lot of position. If you are using a faceball, you have the same position like in the horizontal and vertical plane. It's very easy to do this. We have this component. Always we are doing, for a case like these models, like in the pictures, with 2 pins, we cut everything, and after that we grind, and we realize after that the VAC sequential. So this is the laboratory part. We put the model, we check everything to be in the right position, and then we put the plaster, special plaster without contraction for the articulator. This is the special plaster, and then we program very easy. This is 1-2 minutes. So after mounting the models in the articulator with the support of the faceball, and after programming the articulator, the dental technician will be guided by the mandibular dynamics reproduced on the articulator. And if he will realize a longer tooth, when we are doing protrusion or lateral ottrusion, everything it will be broke, and the articulator gives him the right length, the right position of the incisal plane, because the incisal plane is very important for the aesthetic. Which after that, the result are very correctly. And we know the exact position of the crowns and of the veneers, because the aesthetic is not only the vestibular part, it's also the incisal part, it's incisal plane. And if you put in the right position this incisal plane from the upper superior front and lower front, you will have a very good aesthetic, and also you'll have a good protrusion, good canine guidance, and you'll have everything very easy. The dental laboratory does not receive all the data to correctly program the articulator and to correctly execute the transfer of the jaw position with the faceball and with the condylograph. Then the resulted prosthetic work, which will be going through a random realization without guaranteeing the functionality required in the mouth of the patient. So in this stage, we have the patient in the articulator and we start to understand the case. We program the articulator and we start with the functional sequential VAC diagnostic. And this is very easy. We grind everything and we realize in VACs this kind of modeling. So in red, we have the ICP, the static contacts, and with green, we have the support movement, we have the dynamics, and and this is the dynamics on the articulator, and with blue, we have the vestibular arc. We have the limit of the volume, yes? And it's very important. And these are the movement, left and right. And this is the most important part of the case, angle key, yes, and key of occlusion. And we do everything. After that, we know the limitation of the cases. And we can start to restore everything. I take off the work I take the superior work. You can see here what I find. A lot of problems, yes, left and right. We use always Carey's indicator to clean everything very good. This is the inferior part, left and right in the posterior. And then I start to prepare for veneering. So it's re-preparing because it was prepared for another colleagues. And I'm using my concept horizontal preparation protocol. This is the set for veneers. This is the last set you have. On my last set, you have this kit in metal and you have a QR code you can scan. And after that, you can go on our website and in the Comet site, and you can see movies with this concept. Then we start to use the retraction cord. And these are the final result after taking off the cord. There are some details. And then after that is the second face bow, because we grind everything. First, we do the face bow with the teeth, everything. I'm not touching the patient, only 2 impression, condylography, and then centric occlusion. And now I take off everything and I'm starting again to do the job. And here we have another movies. How easy you can record the face bow. After that, we transfer everything in the lab. It's very easy to transfer. And they realize the temporary crowns because now we are in centric occlusion and we are in the same position, centric and ICP. And it's very important to have this. These are the temporary crowns. And they copy everything. What we are doing in the VAX, they copy in this temporary. They superimpose, they scan the VAX, they scan the preparation, and then they superimpose. It's very easy. If you have 3 points, it's very easy to superimpose. And these are the provisionally in the mouse, in the new therapeutical position. Yeah, right, left. And these are the final works. You have some details from the lab. And this is the final result. So if we look at the dental aesthetic only as a whole of the vestibular faces and as their static relationship with the lips and indirectly with the facial aesthetics, then we will have only a static, incomplete, and non-functional treatment plan. I'm sorry to say that. So this is the final result, but this result must be functional first, and after that aesthetical. So this is the final result with vestibular texture, with translucency, mamelons, everything. Yes, but the functional dynamic analysis is very important for this case. And this is the functional dynamic analysis. We put in the mouth, yes, with fit checker, and then we check. And this is the protrusion. You see before and after the protrusion, because this patient have sagittal condyle inclination left and right, let's say 18 degrees. So it's very important to have a group control. That's why the problem was to change the position of 2.1. And it's when these patients go in protrusion, she goes directly. She don't open a little bit the mouse and go. And that's why it's important where we can put the incisal plane and what we can do for her functional and then aesthetically. And this is the ICP in red. Yeah, we have the contacts. And this is in blue are the dynamics, canine guidance and everything. In this case, we have a group guidance because the sagittal condyle inclination are very low, 18 degrees. And it's normal to be in this way. And this is the dynamics and also ICP to see the contacts. And this is same on the lower jaw. And all these planes, what you can see in these pictures on the central and lateral inferior incisors are guided by the mandibular dynamics. And it's very easy to obtain this result from the functional part if you have the condylography, and it's very easy. And this is the ICP, yeah, intercast position. And then we can check, we can do another condylography to see if the temporary position is the same with the final result. And you can check. I prefer to do the second condylography for checking. And then we can check electronically how is the bite. You see here the result from Occlusense for Bauch company, and it's a good bite. And now we'll talk a little bit about aesthetics. Aesthetics, it's a branch of philosophy which appeared a long time ago and which tried to standardize the beautiful and the natural appearances. This philosophy has not yet reached a consensus. It is in continuous transformation, which is absolutely normal, since it's not an exact science. And now I will come with conclusion. If we look at dental aesthetics, only a whole of the vestibular faces and as their static relationship with the lips and indirectly with the facial aesthetics, then we'll have only a static, incomplete, and non-functional treatment plan. I'm sorry to say that. If we look at aesthetic as a result of convex concave of the palatal faces of the lower and upper frontal teeth, functional space, and the incisional transition plane between the vestibular faces and the palatal faces, then we understand that the anatomy is the first factor that dictates aesthetics, and then the limiting ranges, inside of which we can lengthen, widen, and tilt the volumes of future dental veneers. So aesthetics content is individual and subjective because it depends on the eye anatomy and the level of competence of the observers. Within this function range, the team can realize functional and aesthetic restoration. With functional teeth redesign, you can have a very good result. Unfortunately, not all the cases can be treated with veneers that satisfy the aesthetics requirements of the patient due to the mandibular dynamics, which are specific to each individual. And the conclusion for today is the anatomy is the golden rule in aesthetics and not the relationship between height and width of the vestibular face. And here we have a movie. I present this movie, I think, 4 years ago in the International Aesthetic Congress. And this is a conclusion for today. So this was a movie, and now I want to invite you in Istanbul to Greatest, and this is the movie for functional 2D design. It's like a conclusion. Thank you very much for your attention.
Thank you very much for your great presentation, Andy.
Thank you.
Hope to meet you in Istanbul in October.
Yes.
Yeah.
Thank you.
Dear colleagues, if you have questions, you can put in the chat box your questions. So then we will give a 9 minutes break. Okay. Christos is here, Besim?
Yes.
Okay.
Yes. We have question?
Not yet.
Okay.
Okay. Thank you very much again.
Thank you for your invitation.
Thank you.
Okay, see you in Istanbul.
Regards to Bucharest. Okay.
Yeah.
Yeah, I hope I am in time. I think it's.
Yeah, yeah. On the time. Everything is on the time. Thank you.
One question about the information from the Candular. Can we shift it into 3Shape or ExoCAD software and check with Articulator?
Yes, we have also the virtual articulator, and now it will be on the market, the Arcus Digma 3, and you can transfer everything in ExoCAD. But for a case like this, it's if you are working, if you work only digital, you can have some differences, and one small or two differences can be very big in the mouse. And for cases like this, I prefer to do it digital and analog, to do the functional VAX-UP diagnostic, recording to the skeletal class 1, 2, or 3, and then we can copy this VAX-UP like in the cases, like in the case for today, and it's very predictable. We have a long experience with digital working, also with intraoral scanning and virtual articulators with trios, but sometimes we have differences. Yeah. Not every case can go digital. If you have, let's say, a patient with the laxity and the mandible goes in this way, this patient must be stabilized very well, and then you can go digital. If you have only one tooth in the last movie presentation, it's very easy. We go everything digital with intraoral scanning, printed model, and then virtual articulators. But only for one tooth. If the patient have some TMG problems, some derangement, and full mouth restoration, it's important to do it, in my opinion, analog. Because in digital, you can do everything, but there are some differences. Yeah, I know it's more difficult maybe when you see a case like this, go digital, VAX-UP, everything, but you don't have surprise to the end. But I hope in the future this problem can be solved, to do everything digital. Yeah, but it's difficult to, the problem is centric occlusion, not intraoral scanning. And it's difficult to keep the mandible like this and to scan after you prepare everything. It's difficult. And then you can bite and you can scan the occlusion, but we are using for stabilizing the occlusion, the centric occlusion, we are using, I can show you, I think I have here, we are using some two device for Gothic arch. One moment, please. Avem de arc gotic aici, să vă arăt. Dar nu știu eu pentru arc gotic, dispozitivul ăla. One minute, please. My assistant will give me. And we have, you see, this is a functional wax up. It's full mouth restoration and it's analog, yeah, but it's more predictable to do it in this way. And then you can superimpose. You can do everything with this. We use this from the start to the final. You know, we use this wax, and then we have this appliance for checking the bite. We have something like this with a screw. But I can show you, I have another presentation. If you want to see, I have another one here. And it's...
But we have only just 2 minutes, Andy.
Yeah, no, it's only one.
Okay.
I will share you the screen. Oh, it's not here. Oh, yeah, look, it's here. And this kind of things. It's sharing?
Yeah, we can see.
Yeah, you see, we have for the upper part and with this screw, and then we have the lower part. And we put the patient, and then we record, and this is the Gothic arch. And this is for checking, let's say, and for centric occlusion. Because without this, the mandible, when you prepare everything, it's changing, you know? And you don't have the control, the full control for this. Can you hear me?
Yeah, thank you.
Yeah.
Okay, thank you very much.
Okay. So it's very easy. It looks complicated, but if you have the condylograph and it's one Arcus Digma, two, it's 10,000 euro. You record everything, you have the treatment plan, you have everything, and all the dental technicians will love you because they don't redo the work. Yeah. And in my opinion, everybody can do this. It's not complicated. If you have patient with problems, with TMG problems, that is another part. That you must have a learning curve, you know, from times. But for simple cases, 95% of them, you can use very easy a condylograph and you will have a very good result.
Thank you very much.
Okay, thank you very much.
Thank you very much.
Time is over. Thank you. Dr. Zeynep, are you there?
Yes, I'm here. Thank you for your presentation, Doctor.
One question, please.
There is a question. I think someone asked.
Yes,
please,
yes,
I want
please.
to ask. I'm Ibtisam.
Yes, please.
I want to ask about this manual that's chemical registration for lateral movement. This manual one. How can I mount articulator and fix it the minute angle? Manual, not digital. At the last one, he showed me the photos.
How you can guide the mandible in centric occlusion, or
the last photos when you use a blade, upper one with the screw and the lower one, your registration, that's on the shape like triangles. Then this one is manual. If I want to mount articulator, how can I fix it?
Yes, we put the bite material. You put bite recording material, and then patient close the mouth. And with that pin from the superior part, you will have the DVO, vertical dimension. And then you transfer this to the lab.
I'm in the lab. I'm dental technician. How
Yes.
can I use that one on my articulator in my lab? How can I understand the Bennett angles?
How you understand what? I can hear you.
The Bennett angles. How can I
Bennett
fix it?
angles.
Human
Bennett
secrets.
angle. Yeah,
Yes.
no, this is only for vertical dimension. And the Bennett and the sagittal condyle inclination, medial side shifting, shift angles, you'll have the report for the condylography.
Okay.
This is only for centric occlusion. It's only to put the mandibular bone in the right position, right therapeutical position.
Okay, thank you so
It's
much.
only for that. Yeah. And from this position, you have the models, and then you programming the articulator, and you have the movements. And you start to build the occlusal plane. We start to build the occlusal key, angle key, everything. Always we start with the first inferior model and the first superior model. Yeah. And always it's important to have contacts, every tooth to have contacts with two antagonists, to be like this. Yeah. Not
Yes, understood.
tooth in tooth.
Thank you so
Yeah.
much. Thank you so
Okay.
much.
Okay, welcome.
Okay, thank you very much. Okay, Dr. Zeynep, we can continue with Christos.
Okay, our last speaker is Dr. Christos Krasadakis from Greece. He is graduated from the School of Dentistry, University of Athens in 2006. Following that, he studied at the Medical School, University of Athens, and graduated in 2010. In 2011, he worked as a resident in general surgery at Evangelistria Hospital of Tripoli, Arcadia. Since 2012, he has been a member of the Department of Oral and Maxillofacial Surgery at KT General Hospital in Athens, one of the biggest hospitals in the Balkans. And in 2016, he successfully completed his residency training. He has performed and participated in numerous aesthetic, oncologic, and reconstructive surgeries in the oral, head, and neck area. Since 2015, he has been a member of the postgraduate course in metabolic bone diseases of University of Athens. He has also delivered numerous presentations in Greece and international scientific conferences. Over the last several years, he has been practicing in facial aesthetics and facial injectables. He is also the head trainer of the Australasian Academy of Dentofacial Aesthetics in Europe, focusing on training doctors to incorporate facial injectable treatments into their daily clinical practice. Since the year 2016, he has been the president of the Facial Aesthetic and Rejuvenation Academy of Greece. The topic of his speech is, "Can dermal fillers be safe? Anatomic considerations while using hyaluronic acid." Now the chair is yours, doctor. Thank you.
Hello, everyone. Is my sound good? Do you hear me?
Yeah, perfect. Thank you.
Perfect. Hello, everyone from Athens. I'm Christos Krasadakis. Let me put my presentation on. Just a minute. Can you see the presentation?
Yes, we can see. Perfect.
Thank you. First of all, I want to thank you for the invitation. I want to thank the Knightsbridge Academy for this invitation. I'm really glad that with you today. The topic that we're going to analyze is a little bit different than the previous topics because it has to do with facial aesthetics, and we're going to analyze the safety regarding the dermal fillers and specifically the hyaluronic acid. And before someone starts incorporating this kind of techniques in the daily practice, before someone starts injecting with hyaluronic acid, they think it's something really easy. And actually it is. It is really easy, but in order to achieve that, we need some things to have first. Everyone's perspective on aesthetic procedures is that we have easy clients, smiling clients, and a lot of money. This is the case, but you have to exercise a lot to achieve that, because there's the other side, the reality that if you don't know what you do, that you could destroy a face, that you could cause problems that are not easy to solve. And if we want to be thorough and good in what we do, we have to know our anatomy. I do not want to discourage you with this lecture. You're going to see some things and you're going to say, oh no, I'm not going to involve myself with, I don't know, facial aesthetics and like that. But my purpose is completely the opposite. I want to encourage you to start injecting if you're not already, because it's something really safe, but you have to follow some rules. The first rule you have to follow is the most known Hippocratic rule from Hippocrates. It's the do not harm rule. You do not have a patient there, you have a client. They don't have any diseases. They are normal people that come to look a little bit better. So it's important that they remain normal. So the second rule you have to remember is that you have to combine aesthetics with ethics. Many clients are going to come to you and they will say, I need more lips, I need more zygomatic, I need more. And you have to say no sometimes. Because the first one that spoke about the good combination with aesthetics and ethics was Plato, with the saying kalos kagathos, many years ago. And as we say, ignorance is bliss. If we don't know what could happen, if we don't know the side effects, okay, we are safe, but this is not the case. In rare cases, we could have some difficulties, some side effects, and we really need to know our anatomy before we start injecting. If we know our anatomy, if we know the pharmacokinetics of Botox and fillers, then we are completely safe. What I can tell you after thousands and thousands of treatments is that I'm never worried again, I will never worry again for something bad to happen. Okay, I may not have the best result, I may not have the perfect result in some patients, and they may need to come back and do a follow-up. Okay, that could happen to anyone. I could have some bruising, I could have some edema. Okay, that's normal, but I'm safe. I'm not going to cause any problems that will remain after 1-2 weeks. Okay, and this is not because I'm a great injector. This is because I have what it takes regarding the anatomy and regarding the knowledge about the drugs themselves. So hyaluronic acid sounds like a really safe substance. We think, okay, so hyaluronic is safer than Botox, but actually it's something completely different. Many patients come and say, you know, I need to have hyaluronic acid here, not Botox. I don't like Botox. I'm not familiar with Botox. I need hyaluronic acid. And yet you have to understand they're completely different and they focus on completely different things. First of all, hyaluronic acid cannot do anything on dynamic wrinkles. On the contrary, it revolumizes lost volume of static wrinkles. And let's see the difference on that. I'm going to stop sharing so that you can see me. So I'll give you an example. Okay. What is a dynamic and what is a static wrinkle? Okay. And whether we can use Botox or filler. Let's see my forehead. Okay. If I ask the patient to lift their eyebrows, so they do a contraction on the frontalis muscle, so I lift my eyebrows and frontalis muscles contract, what I see is these horizontal lines on my forehead. When they stop contracting, I cannot see those lines again. So these are dynamic wrinkles. They are not static. On the other side, if I have a wrinkle like that, you know, perpendicular like that, even if I lift my eyebrows, this is not going to get any different. So this is a static wrinkle. Or my nasolabial folds, these are static wrinkles. So actually, fillers are aiming static wrinkles, folds, and osseous bone structures. So if I want to enhance a bone structure like my chin, like my cheekbones, like my nose, like my temples, I will need a filler. And the most known and the most safe filler is hyaluronic acid. Okay, but if I want to fade away my dynamic wrinkles, those that appear after muscle contraction, I need Botox. So they are completely different materials. And what will happen if I put hyaluronic acid on a dynamic wrinkle? Two things. First of all, the muscle will continue to contract, so it is going to throw away my hyaluronic acid, so there's not going to be any result. And the second thing is that when we are not contracting, when we are relaxed, you're going to see a line with your hyaluronic acid, because hyaluronic acid is a static filler. So first of all, we have to distinguish these two things. And regarding the filler complications, there are many filler complications like bruising, like edema, like some redness that are common, like pain, and they are going to be solved in about hours or 2 days or 1 to 2 weeks, mostly. But there are some relatively unusual and some rare cases that we have a complication that is a little bit more difficult. And you can see the underlined complications, like the granuloma and the Tyndall effect, that anatomy plays a really important factor there. The knowledge of anatomy can save us from this kind of complications. Let's start talking about granuloma. What is a granuloma? It's a firm papule or a nodule. It's a small thing that you can feel after having a filler. And it's not something usual, but it could happen. It's not something that rare. And what is a granuloma? It's your hyaluronic acid, as you can see here on my presentation. And it's surrounded by fibrous tissue. Okay, so this is the granuloma. It's hyaluronic acid surrounded by fibrous tissue. And you have T lymphocytes, B lymphocytes, neutrophils, macrophages. And the factors that could cause a granuloma formation are many. And granulomas are distinguished in real granulomas and pseudogranulomas that are not actually real granulomas. So the real granuloma, that is hyaluronic acid and fibrous tissue, has to do with bad filler quality and the foreign body reaction. In some cases, some patients do a much bigger reaction with the hyaluronic acid than they should, and they form this fibrous tissue. But it's the other category, the pseudogranuloma, that actually it's not fibrous tissue, it's the filler itself. And this has to do with your technique. It's a wrong technique. You put the hyaluronic acid, but you didn't put it homogeneously. You put some here, some there, and the patient could feel these balls of hyaluronic acid that you put. You didn't massage them, you didn't make it homogeneous, and this is the problem. And another thing is that you put it a little bit superficially, and this is an incorrect placement. And as you can see, this is the correct placement of the filler inside the lip, and the second picture is the incorrect. And this could look like a mucocell. You open the mouth and you could see some small mucocells, like it's the normal mucocells, but it's not mucocell. It's a filler that is really superficially under the mucosa. And when we have granulomas, we could have a lymphedema. Why? Because here you can see the lymphatic system of the face, where all the lymphatic vessels are outside, in the outside of the face, and they're running downwards. And if we put hyaluronic acid in some areas, and we could cause granulomas, so the lymphatic flow is not working really well after your hyaluronic acid. So you could have lymphedema, and you could have your patient coming back and saying, you know, I got swollen again. And you could see really big swelling, and you could say, what to do now? So there are 3 solutions about granulomas. First of all, the surgical removal. You can touch it. It's a really superficial, and you can touch it, and it's movable. You could pinch it just with a needle or a small blade, number 11, but it's pointing, and then remove it. I'm going to show you some examples. Or if it's not something that you can see, and if it's not something that the patient feels, and you can just, you know, feel it like that, you could just follow up. So if the patient comes back and doesn't complain about lymphedemas, it's not something that you could see, and it's not something they're complaining about, but you're touching it, you could just say, okay, I'm going to follow up now and do nothing more. But the third thing, and the most common to do, is put a very common enzyme that it's called hyaluronidase. It's the enzyme that dissolves hyaluronic acid, and have your granuloma removed. Because as you remember, as I told you, it's fibrous tissue, it's thin fibrous tissue, and inside it's your hyaluronic acid. So if you put the enzyme that destroys hyaluronic acid, the center part is going to dissolve, and the small part of fibrous tissue is not going to be felt again. So what is hyaluronidase? As you know, it's an enzyme. It comes in a single vial, single-use vial. You put some sterile saline inside that you reconstitute, and then you put in about 1 ml of hyaluronic acid that you used, 0.5 ml of hyaluronidase to dissolve it. The thing is that you have to be really careful is that in some cases, hyaluronidase could cause allergic reactions. That's why we do a small test like the Madu test here on the arm, and we put just 1-2 units on the arm, and we check it in about 15 to 20 minutes. And if we find some redness or wheal that persists, then we have to stop using hyaluronidase, and then having in mind to use the surgical removal. And let's see what hyaluronidase does. In about 48 hours, it's going to dissolve all your material. Okay, the material that you put. So it's going to give you the result on the granuloma. And this is a pseudogranuloma, as I told you, on the lip, like a mucosal. It's a really superficial filler that you put wrong. And then with just a needle, you can throw away the material and give solution to this granuloma. And this was from the inside, from the mucosa. Let's see it from the vermilion side. And this is just with a needle again. And you can see the material on my glove. Okay. So after the granuloma that are not something that rare, but it's not something that common, we have the Tyndall effect. What is Tyndall effect? It's the light scattering. We have to understand that hyaluronic acid is a colloid solution. It has microparticles inside. So if we throw light inside, if we use light inside the hyaluronic acid, it's going to be visible, like the picture that you see. When we put the laser, the first glass has water with no microparticles, and the second is a colloid solution. So when you use the laser, the second solution that is colloid, like the hyaluronic acid, the light can be visible. So what is Tyndall effect? It's the effect that you will get if you put your material really superficially inside the epidermis. The target is the dermis, beneath the epidermis. If you put it superficially, what you could get is this. Your patient complaining about the bruise. They're going to tell you, I got a bruising. And you're going to say, don't worry, it's going to fade away in about 7 days, 10 days, 12 days, but a month goes by and nothing changes. And they say, but I still have the bruising. And then you say, what is it? This is not a bruise. This is Tyndall effect. This is your hyaluronic acid that you put really superficially. And what is the solution? This enzyme again, hyaluronidase. So you keep your enzyme inside your fridge, and if something comes back like this, that you understand that this Tyndall effect and not just the bruising, and how you will understand it, by the time that it's going to pass by. If someone comes and says, okay, I've been having this for 3 months, I went to another doctor, they put the hyaluronic acid, and I have this bruising for 3 months, like the first patient I'm showing you, you're going to say, okay, we have a Tyndall effect, we have to dissolve the material, because no bruising lasts for 3 months. It's not a hematoma, and even in hematomas, you're going to see a better image after 3 months. And this is what you did. The incorrect placement is that you put it really, really superficially, like in the second picture. And the other thing that you could cause is the filler migration. And factors to have your filler migrated are the use of not the ideal viscosity. In some cases, like the bone structure, you have to put really hard materials. They need to be hard, not soft materials. They need to be viscous materials, so with high viscosity. So if you put a soft material there, you could have some migration. The other thing is that the patient could apply some pressure. You put your zygomatic arch perfectly, and they could rub it without having your instructions say no, and then you could find your hyaluronic acid below or above from the area that you put it. Another thing is that you could have an incorrect level of placement. You could be really superficially, not like the Tyndall effect, but you could be really superficially than the bone, because when you fix a bone, you have to be supraperiostally, you have to be just above the bone. If you are inside the dermis, then you are really superficial, and this could easily migrate. And these are some examples. This is an example of migration on the lips. And you could see here, this patient came to me with this filler that it's inside the skin and not inside the vermilion that she wanted it. She wanted bigger lips, not bigger skin. So this is the normal duck face that we say in aesthetics. It's like this protrusion that we have with the upper lip. And what we did there? Hyaluronidase. This is the thing that we have to respect. We have to respect the anatomy, and we have to respect the pharmacokinetics. If we have our enzyme that dissolves the hyaluronic acid, we are safe, even if something goes wrong. And then you're going to say, okay, in that case, I'm going to use hyaluronidase in every case that comes back. But this is not the case, because if you do that, that means that a patient or a client paid for a treatment and they got the treatment wrong, and then you have to pay more to dissolve it. And then you have to give the money back. So the first you have to respect is not the pharmacokinetics, is the anatomy. If you respect the anatomy, then everything will follow. And a knowledge that you should have about the hyaluronic acid is that it comes with two factors. It's the G prime and the G double prime factor. And the G prime factor is the elastic force of the gel. And you have to remember that, let me stop sharing again. What is an hyaluronic acid? It's a gel that is inside a syringe, and then it comes through a needle to go inside your skin. And you have to understand that this is going to stretch a lot inside the needle, and then it's going to come inside your skin. You need it not to be like that stretched, but you need to be like it used to be inside the syringe. So the higher, let me share again the screen. Can you see my screen again?
Yes, you can see.
The higher the G prime is, the best elastic force we have. So it's going to take the original shape again when you put it inside. So when you want to build like your chin or your cheekbones or your nose, you need to have really high G prime. When you need to build your lips and give volume to your lips, you need to have high G prime. Not that high as the bone structures, but high enough so that they keep the original shape and it doesn't spread away, so that you could have some actual result. But the cheek enhancement is always a good idea? No. This is a photograph that I took from the internet, and it was from a website of a plastic surgeon that it was the before and after image of a patient. But this is not something that we could be satisfied. We have two big apples on your cheeks, and nobody is going to be satisfied, and everybody will think, okay, it's a little bit swollen, the face. So you have to understand that if we know our anatomy, we are going to build the zygomatic as we should. So that's why when we train people with the Facial Aesthetic and Rejuvenation Academy, we teach them how to do it properly, how to do it with respect to the anatomy. So we mark the patient. You can see our lines. For instance, this is a line that connects the lateral canthus from here to the upper tragus area of the ear. And this is a line that connects the lateral canthus to the lateral commissure of the mouth. And this is from the lateral commissure of the mouth to the middle tragus. And inside this area, you have to put your filler. And if you connect this line, which comes from the the inferior third of the nose to the tragus, again, it's going to be the most prominent part of your cheekbone, of your zygomatic. And if you put more filler there, you're going to have suspension of the face, and then you're going to have this that we call liquid lift, lifting the nasolabial folds and having a good result. And this is how much hyaluronic acid we use. It's not the same in every patient, but this is something that could work in many cases. And let's see again the result that I showed you before. This is the most prominent part that they built, but if we had drawn the lines, this is where the hyaluronic acid should be. Not here, but here. Okay, and then you get a more natural result without having this apples and this swollen face. And you have to respect your anatomy, because this is the zygomatic arch that I'm showing you, and this is the area that your material should be, right above the bone, and not superficially like that, inside the fat or inside the skin, because if you do that, the material could migrate, like we said before. And another bad thing that could happen is the biofilm. What is a biofilm? It's an inflammation, but it's a bad inflammation. It's not something that we could say, okay, let's give some antibiotic administration and okay, we're going to solve it, because it's a little bit more difficult. And you could see some cases of biofilm. A face could be destroyed by a biofilm. How could a biofilm appear? It's easy. I hear a lot of doctors using some filler inside the patient, inside the skin of the patient, and then they have some left. And what they do, they change their needle and they put it on someone else's skin. And this is a common practice, not something that I heard from one guy. It's a really common practice. But if you put the material inside the skin of a person, of a client, of a patient, it's going to aspirate microbes, it's going to aspirate blood. And then if you change the needle, you're giving material that it's aspirated and full of microbes and could cause biofilm. So what I suggest is that you prepare the face when you do injections, filler injections, prepare it with octenicept or chlorhexidine, and then you inject. And remember, each syringe is for one person and use it on one person. Don't change needles and use it in many persons. Another bad thing that we could have is the allergic reaction, but okay, in this case, it's not something that we could control with anatomy. It has to do in many cases with bad filler quality, with the area of placement, because the upper lip is the most common area, with the hypersensitivity that some clients or patients have, and with unknown factors. And the most common area is the upper lip. And maybe you've heard about some side effects regarding the mRNA vaccinations that we have with Pfizer and Moderna, most commonly with Moderna, and patients that had fillers even 1 year prior to the vaccination. And these cases were cases of angioedema of the upper lip, like the one that you see. And it's really frightening to see it, but it's not something that we are going to have difficulties to solve. You have to start treating with corticosteroids like Medrol, cortisone, okay? And then you can give some antihistaminic administration, and then after 2-3 days, you put hyaluronidase. You dissolve your material. You don't put hyaluronidase immediately, because if you do it, you could cause a spread of the allergic reaction, because the hyaluronic acid will dissolve in many particles, and this could cause a rebound in the angioedema and the allergic reaction. So you start with corticosteroids, and after 2-3 days, you put the hyaluronidase. So in all of these cases, what is the solution? Is hyaluronidase. Okay, but in some cases like the biofilm, you have to be really careful before, because okay, the hyaluronidase could give you a solution, but you could have some bad skin quality after that, and some discoloration with hyperpigmentation, like the previous picture here. You can see there's also a discoloration. We could give some antibiotics, we could put some hyaluronidase to dissolve the hyaluronic acid, but this skin is going to look different after that. And one thing that really it has to do with anatomy is vascular occlusion. And these images are not something that you need to see, okay? The skin necrosis after hyaluronic acid. And what I told you in the beginning, I don't want to discourage you. If you know what you do, this image is going to happen. It's not going to happen in any case. It's something that it has zero possibility if you do it correctly. But if you start watching videos on YouTube and then you start injecting, yes, you could have these images in your practice also. These are the danger areas of the face. And many years ago, I was in an aesthetic congress like IMCAS in Paris, and a dermatologist showed this picture and they said that it was from a patient with vascular occlusion, and then you can see the embolism inside. This is the hyaluronic acid inside the vessel, inside the facial artery. But after this lecture, I was really concerned, and I said, okay, but it doesn't explain when we as surgeons cut the facial artery and the facial vein in every surgery we have. This should necrotize the whole of the skin of the face, but it doesn't, because we have excessive vasculature in the face. The facial vasculature is amazing. We have a lot of collateral vascularization, so we don't get a necrosis. So the embolism doesn't explain why we have skin necrosis after hyaluronic acid. And now I'm going to explain the problem. The problem is that you put a lot of material, and putting a lot of material, you cause the occlusion of the underlying vessel, the underlying arteries, because you put a lot of material and they press the underlying vessels and they don't give blood supply anymore. And the problem is not only this, because as I told you, this could easily have an argument that said, okay, and if we cut the vessel, we don't have a necrosis. The problem is that this ball of material that you put causes also pressure on the overlying skin. And what you have, no collateral vascularization, no blood supply can pass through this pressure. And what we see when we have this kind of pressure on the overlying skin, a white spot. You're going to see a white area where you put your hyaluronic acid. So after every treatment, you have to check the skin. If you see white spots, you have to do something. And what you have to do, you have to find a solution. Otherwise, you're going to see images like that. And as you can see, the anatomy is specific. The distance between the facial artery and the nasal ala is about 6.7 minus plus 4.4 millimeters. So the facial artery runs through here, as you can see with my cursor, and gives the inferior and superior labial artery and comes here, and it has this distance 6.7 millimeters away from the nasal ala, around here. And it gives the lateral nasal artery and continues as angular artery. You have to know this, you have to have this knowledge in case you inject hyaluronic acid. And the second thing, and most important, you have to know the depth. It's deep. And this is the problem. It's not only deep, you can see the artery here, and this is the area that we have the vascular occlusion. This is the area. The problem is that it runs in this area, in this specific area here, it runs right down the deep medial cheek fat pad. And what it means, it cannot be moved. It's really firm. It's right above the periosteum, right above the bone. So in all the other sides of the facial artery, you can move it. So if you put hyaluronic acid, it's going to move the artery away. But in this area, if you put a lot of hyaluronic acid, what you could cause? Occlusion. It cannot go away. So this is the problem. That's why we have this kind of images. So if you know your anatomy, nothing wrong is going to happen. Even if you don't know your anatomy that well, you have solutions. You have to see and always check for white spots. You're going to see a white spot. If you find a white spot, you have to do something. And the problem is not only on the nasolabial fold, the problem is on the nose as well, the problem is in the forehead as well. But the incidence of skin necrosis in the nose, it's 1 in 100,000 cases. And we could give this really normal and good result with hyaluronic acid, and the risk is really minimal. But we could have zero possibility, we could have zero possibility when we know our anatomy. Because in the case of the nose, you have to inject in the center, not laterally, in the center. This is the right technique, in the center, not here that we have the dorsal artery of the nose. Okay, in the center, and you have to be deep, right above the bone, right above the perichondrium. Okay? And these are images of lip vascular occlusion. And the anatomy of the lips is that we have the upper labial and the lower labial, the inferior labial artery. And the problem there in the lips is not the anatomy, is that you put a really hard material. Many patients come and they say, I need my lips be done really big. And then you go and put the hardest material you have to give good results. And this is the risk you get. You have to put medium viscosity materials. And this is also the case for the forehead, because we have to respect the anatomy of the supratrochlear and the supraorbital artery. And those two arteries, like the facial artery here, cannot be moved here in the glabella. And as I told you before, here for the glabella, the material of choice is not hyaluronic acid, it's Botox, because they are dynamic wrinkles. So you risk with skin necrosis and you put the wrong material when you use hyaluronic acid. So can we minimize the risk about regarding all of the aforementioned mentioned? Yes. First of all, we could use cannula instead of needle, so we don't penetrate the vessels. This is always something that we could use and be safe. No, the answer is no. Actually, I use about 80% of my cases are with needle, 20% of my cases are with cannulas, but it's something that you should have in mind. The second thing is the aspiration. Always use aspiration to be safe. But there are some cases, you can see this aspiration, the needle was inside the upper labial artery, and we stopped injecting after aspirating the blood. Okay, but this is the most important rules. Thirdly, you don't put more than 0.5 ml in one session in one area. If you need more, do it in a next session about 10-15 days later, minimum. So don't put enough because the patient complains and wants in more. No more than 0.5 ml in one session in one area, and no high viscosity fillers in very delicate areas like the lips I told you before. And another important factor, what I told you, the white spots. If you put the material, it's going to close the vessel, it's going to cause the white spot because of the pressure on the skin. And what you do, you rub vigorously. You do this, rub, rub, rub, rub. And when you do this, it's going to be applied in more surface, and then you get collateral vascularization, and immediately you're going to see the skin getting pink. And if you see this after you're rubbing the skin getting pink, there's no chance to have the skin necrosis. So even if you don't know your anatomy, just start checking about white spots after you put your material. And even if you forget about it and the patient goes away and calls you and says, okay, Dr. Christos, I have a lot of pain, you should say, come back the first 12 hours to see you again. And if I see something, what I do this vascular occlusion protocol. First of all, I rub, rub, rub, rub. If I don't have a change on the skin, what I do, I use hyaluronidase. And everything is back to normal. And there's a chance, a really, really, really rare chance to get blindness after having fillers on the face. We have 34 cases that are reported worldwide. For example, in Greece, we don't have not even one case. And in Europe, the whole of cases are 4 of the 34. And in those 34 cases, not all of them were treated with hyaluronic acid. Many of them, the 25 of them, were treated with fat autologous fat. Okay, and what we had an embolism. We had an embolism. They put the fat inside an artery, and they had this paradoxical embolism regarding the ophthalmic artery. And the patient said, I cannot see. And if you have something like that, you understand this could be a really, really big problem. So what we learn our students to do, cannula when you use some material around the eye. Always use the cannula, because when you use the cannula, let me take you back to the cannula. It's here. See, the cannula is a needle with a blunt tip. It cannot penetrate an artery. It cannot penetrate a vessel. So if you use a cannula when you have treatments around the eye, you don't only minimize the risk, because the risk is higher for me to get out with 40 degrees Celsius here in Athens and have a lightning struck, okay, a thunderbolt on me. The incidence of blindness, when we have billions of treatments every year, is close to zero. But if we want it to be zero, use cannula when you have treatments around the eye. And then you're going to be completely safe. And lastly, nerve damage. Actually, what I can say is that no nerve can be damaged with hyaluronic acid. They could be damaged from your needle, your injections, but this is extremely rare and you have to be really not careful. So don't have any worries about damaging any nerves when you use fillers. So thank you very much for your attention. What I need to say in conclusion is that you need to respect anatomy. You need to improve yourself continuously when you want to inject and when you want to become a good injector. Thank you very much.
Thank you very much, Christos, for your great presentation. My voice is open.
Thank you very much for all attendees who share with us the first Knightsbridge Academy. We are very happy to share with you all this nice lecture, and thank you for all the speakers about very nice lectures they share with us, and wish to meet again with courses in Dubai and also in online courses. We are very happy to share with all the speakers and to share with Knightsbridge Academy in UK all the courses that we will run in October. After 2 months, we'll share the first course about orthodontic in Dubai, and everyone interested will send him all the information about this upcoming course. Thank you very much.
Thank you.
Have a nice evening for all, and wish to meet in future in upcoming courses and webinars and seminars. Thank you very much.
Thank you very much. Christos, regards to Athens. Okay.
Very nice to see you again, William.
Yeah. Hope to see you soon, face to face again. Okay. Bye-bye.
Bye.
Thank you.